Okay, so welcome everyone to the first free lecture of the new batch for Dr. Hydra Step 1 for the new batch of students. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I get a yes in the chat box, please? Good. Oh, thank you so much. Before we begin the lecture, I just want to inform everyone over here that if you want to ask us something, then we would much rather have you guys use the chat box, which you have on the right side of your screen over there, instead of using your voice. And one last time, is my voice clear? Yes or no? Okay, good. Good. So let me just share the screen over here very quickly, and we can begin our class for today. Okay. There you guys are. Can you guys see my screen? Yes or no? Can everyone see my screen? Okay, good. So thank you so much for joining the lecture. It's 8:35 as of right now, and thank you so much for waiting 5 to 10 minutes to let the other students join our class. So Dr. Hydri's Step 1 lecture is basically conducted to make sure that um, international medical graduates can understand first aid better. And as we all know that our Usmle Step 1 is conducted with the questions being structured from first aid directly. So before we begin the lecture over here, just want to give a very quick presentation on basically what the lecture is, what are our schedules and timings, what are the resources we will use, and after that, we will begin with our schedule for today, which is endocrinology for step 1 from first aid 2021. And without further ado, let's begin. So over here, as you guys can see, that the first thing that I want to talk about is the class timings and the class schedules. And the class timings and schedules are basically from Monday to Friday. It's 8:30 a.m. to 11:30 a.m. That is on the New York Eastern timing. And we will basically conduct the lecture for a duration of about 3.5 to 4 months. And this does not include holidays and vacations. And if there are any discrepancies during the whole duration, then this can extend a little bit to 4 to 4.5 months. But hopefully in the next 4 months, we will be finishing the entire syllabus of first aid along with the UWorld question banks. And I will be there with you guys every step of the way, sort of let you know what to do, what to expect, and everything else. So that's that. Let's move on to the next presentation. That is the resources. Okay. Can everyone see my screen properly one more time? Can I get a yes in the chat box if you guys can see my screen? Okay, good. Now, okay. So let's start with the resources over here. The resources that we will be using is basically first aid for step 1. That is the 2021 edition. And this is provided by us to you guys via your email in a Google Drive. So if you guys do not have access to the first aid step 1 2021, then you can directly download the PDF version from our email. The next thing that I want to talk about over here is the most important resource for step 1, step 2 CK or anything else. That is the UWorld question bank. A lot of you guys will have questions regarding whether I should be using UWorld question bank offline, whether I should be using UWorld question bank online. The difference between online and offline UWorld question bank is offline is free, but the questions, the amount of questions in offline UWorld is limited. And if I were to advise you guys, then I would ask you to get the subscription for the online UWorld question bank. That's that. The next thing that I want to talk about that we will be using is Emboss question bank. This is something which you guys will not need to purchase. We have already purchased the Emboss question bank for you guys. which we will be practicing our daily lectures with in our class. And the next thing is Patoma. Patoma is available online in PDF versions and everything else. If you want to subscribe to the original channel by Dr. Hussein Sattar for Patoma, then you are more than welcome to do so. I will obviously let you know how we will be using the Patoma over here. The next thing is Physio. Physio is basically a picturized version of microbiology, which will allow us to understand the virus, bacteria, parasites a little bit closer with the help of pictures, and it will allow us to remember all the important informations. And that's that. Let's move on to the next one. Let's get started with today's task. Does anyone have any question regarding the resources, timing, schedules, and everything else? If you guys do, can I get a yes in the chat box? And I'll ask the questions right away. Does anyone have any questions? Yes or no? Okay, no sir, by Dr. Salman. Does anyone else have any questions? Yes or no? Okay, no more questions. Okay, very good. So that's that. Okay, good. So without further ado, let's begin the class for today. Today, we are going to focus on beginning endocrinology for step 1 from first day 2021. Before I begin this over here, I just want to ask everyone if you guys have access to your first aid. If you guys do, then can I get a yes in the chat box, please? Do you guys have access to your first aid PDF book? Yes or no? Okay, everyone has their access. Okay, good. The reason why I'm asking you if you have access to your first aid over here is what we will do right now is we will begin the lecture by reading each and every word. I will be using my cursor over here to sort of underline the important questions that we will receive from the text. So I will be using 2 different types of color. I'll be using red to let you guys know that this is a direct question from the UWorld question bank, from the NBNE, and also an embossed question. So basically red is your indication that this piece of information has already been tested in the past years. Blue is basically the cursor that I will use to sort of underline the information over here that has the potential to be tested in the future. And also I'll be using the blue mark over here to sort of let you guys know that this is something that will be tested in the future in the step 2 CK exam, if that's what you will sit for in the future. So that's that. Okay, so without further ado, one more time, is everyone ready to begin endocrinology, embryology? Yes or no? Is everyone ready? Can we begin? No. All right, good. So let's begin with embryology as a whole. A very quick description of embryology is basically what is embryology. Embryology is basically the study of human or basically the human development in short. So in order for the development of human, we have to talk about human genesis. Yes or no? What is human genesis? Meaning the beginning of the totipotent cell. So what we have is we have the mother's cell, that is the ovum. We have the father's cell, that is the sperm, right? There's fusion. And after there's fusion, we have what we call is formation of the zygote. Yes or no? Have you guys heard of the zygote? I'm sure you guys have heard about zygote, blastocysts. Yes or no? Okay. Zygote, have you guys heard of what a zygote is? Yes, of course. I'm pretty sure you guys have heard what a zygote is, yes or no? When there is fusion between the mother cell and the father cell, we have the formation of basically a totipotent ball of cell called a zygote, right? And this happens during the first week of human development, in the first week of human development. Now, if we quickly move on to the second week of human development, we have what we call as the formation of the bilaminar disc, yes or no? At the second week, we have the zygote transforms into something which we call as a bilaminar disc by week 2. And this bilaminar disc, this has basically 2 layers. This is called an epiblast, and then we call this one a hypoblast. And then moving on over here very quickly on week 3, we have the process of gastrulation. Gastrulation is basically the development of this bilaminar disc into a trilaminar disc. Now, can anyone over here tell me the 3 names of the famous trilaminar disc process of gastrulation? If you guys can I get a yes in the chat box over here very quickly? Can anyone tell me the 3 names of the gastrulation? Okay, so Dr. Salman over here, epi-meso-indo mean. Okay, epi-meso-indo is not, it's not quite right, but it's almost over there. Ecto-meso-endo, very good. So we have what we call as an ectoderm, we have a mesoderm, and then we have an endoderm, right? Can anyone tell me out of ectoderm, mesoderm, and endoderm, which layer is responsible for the development of the foregut, midgut, and hindgut? Do not tell me the answer in the chat box. You just write yes or no if you know the answer. Does anyone know the answer? Just write yes or no in the chat box. Which layer, ectoderm, mesoderm, endoderm, is associated with the formation of 3 layers? Okay, so Dr. Dola knows over here. So can you please tell us very quickly by unmuting yourself or using the chat box, out of which one of these 3 layers will the foregut, midgut, and hindgut develop from? Very quickly. Can anyone tell us over here? Let's ask the question to Dr. Dolas, and she said yes. From which layer, ectoderm, mesoderm, or endoderm, will we have the development of the foregut, midgut, and hindgut? Very good. Okay. Endoderm, very good. Okay. So that's basically what it is. Now, from the endoderm, ectoderm, mesoderm, and endoderm, out of all of these 3 layers, the endoderm is basically the layer that will give rise to the foregut, midgut, and hindgut. And from the foregut, we have the development of what we call as the thyroid diverticulum. I'm just going to write TD over here. Excuse my mouse cursor. So from the foregut, we have the development of the thyroid diverticulum. Okay. Is everyone clear, yes or no, how the thyroid came from a zygote? Yes or no, very quickly. Can I get a response in the chat box? Okay, is everyone clear of how the thyroid diverticulum came to place from the fusion of the female and the male cells? Yes or no? Okay, good. Okay, now let's begin. So basically, this is the thyroid diverticulum, which arises from the floor of the primitive pharynx, and it descends into the neck. So when we talk about primitive pharynx, can we understand that the pharynx is basically the development from the foregut? Yes or no? Quickly. If the thyroid is developing from the floor of the primitive pharynx, and then we just talked about how the foregut is developed from the endoderm, but that must mean that the primitive pharynx is also developed from the foregut. Yes or no? Quick answers, please. Yes. Okay. Yes. Okay. Now over here, let's underline this one. This is a question directly from your UWorld, and it's also a question from your NBME, that the thyroid is basically it's developed from the primitive pharynx, and then it descends into the neck. It's connected to the tongue by the thyroglossal duct, which normally will disappear but may persist as a cyst or as a pyramidal lobe of the thyroid. Can everyone see my screen properly? Is the writing blurry to anyone? Can everyone see the screen properly? Is the writing okay? Can everyone see the writings? Okay, good. Okay. Now, so the thyroid is basically developing from the floor of the primitive pharynx. So please underline this one. This is a question of your step 1 of your UWorld question bank and AMBOSS. Then the next thing that I talked about is that it's connected to the tongue by the thyroglossal duct. Underline this over here very quickly. And this duct should disappear as the human develops. But sometimes in some humans, this thyroglossal duct may persist. And this persistence of the thyroglossal duct can sometimes develop as a thyroglossal cyst, which presents as a midline neck mass. So please underline this one, that the thyroglossal duct may sometimes persist as a cyst, and also sometimes there might be some amount of thyroid follicular cells in the thyroglossal cyst that can give rise to ectopic secretion of thyroid hormone. This is something that we will talk about in the future, but that's that. And over here, I just want to ask, is everyone Bachelor of Medicine and a Bachelor of Surgery student? Yes or no? Meaning, is everyone an MBBS student? Or has anyone practiced thyroid examination in their clinical wards? If you guys have practiced thyroid examination in your clinical wards, very good, second year, yes, okay. So quick question over here. If you have practiced your thyroid examination, have you asked your patients to sort of take a gulp of water so that you can see if the thyroid moves up or down, or if there's anything connected? Good. Have you guys asked your patients to stick their tongue out during the examination of the thyroid to see if anything moves when the tongue sticks out? Yes, okay. So do you guys realize why you guys ask your patients to stick their tongue out or drink a glass or drink a gulp of water? Is that because we want to see if there is a remnant or persistent of the thyroglossal duct? Yes or no? Is this why we do that examination? Very good. Okay, so yes, so that's basically why we do those examinations, to see if there's persistence of any sort of connection between the movement of the tongue and the thyroid gland by itself, because it says so over here that it's connected to the tongue by the thyroglossal duct. So if the duct is remnant or if it persists in adulthood, then when you stick your tongue out, the thyroid will move up and down. So that's that. Quickly, let's move on to the next line over here. Foramen cecum is the normal remnant of the thyroglossal duct. This is basically a physiological structure that will be present in all the adult humans. So that's that. Underline this. Foramen cecum is a normal remnant. In your questions, in your UWorld, you will get questions about which one of these is the following remnant of the thyroglossal duct. Over there, you will have a lot of different types of options. From all of those options, you have to choose foramen cecum as the most viable option. So that's that. Let's move on to the next line. The most common ectopic thyroid tissue is the tongue, meaning that in the tongue, there could be a possibility that a little bit of the thyroid gland can remain behind. It will not disappear. It will not basically disperse. And in adulthood, if there is high amount of thyroid hormone, or hyperthyroidism, but we cannot find out the source, or we think that the thyroid hormone is not being produced by the thyroid gland itself. Can anyone tell me what is the next best region to look for the thyroid and ectopic thyroid tissue? Very quickly over here, what is the next best? Very good, tongue. Okay, so basically, that's basically what I'm trying to explain to you guys, that if you guys think that there is an ectopic thyroid tissue, then the next best place where you should look for the thyroid gland is in the tongue. Sometimes it will persist as a lingual thyroid. So that's it. And obviously, if it's involved in the production of thyroid hormone, if you remove the lingual thyroid, then patients can have hypothyroidism. So that's basically what I'm trying to say here. Let's move on to the next one, that thyroglossal duct cyst. As we can see over here, okay, this is the thyroglossal duct cyst on an imaging. It will present as an anterior midline neck mass that moves with swallowing or protrusion of the tongue, okay? So basically, when there is an anterior midline neck mass in your step 1 exam, there are two things that I want you to think about, okay? There are two things that I want you to think about. One of this is a thyroglossal duct cyst. Another thing is I want you to think about persistent cervical sinus. Now, persistent cervical sinus is basically an anomaly, and it's an abnormality of the arches, clefts, and palates, which we will talk about in the future, the pharyngeal arch, the pharyngeal clefts. And so if there is an abnormality in the anterior midline and you see that there is a swelling, then there are two things that I want you to think about. One is a thyroglossal duct cyst, another one is a persistent cervical sinus. Now, how do you differentiate between a thyroglossal duct cyst and a persistent cervical sinus? The answer is very simple. One of them will move with the protrusion of the tongue. Another one will not move when the tongue is protruded. Very simple. So please underline this one over here. Very, very important. Not only is this a basic science step 1 question, it's also a clinical question over here. So these are the two things that I want you to think about. These are basically 1, 2, 3, 4, 5 questions, more or less, that will be structured from this text over here. Let's move on to the next one. Thyroid follicular cells are derived from the endoderm. This is another question. Please underline this with your red cursor or your red pen. And then we have the parafollicular cells. So in the thyroid, we have the thyroid follicular and the parafollicular cells. Can anyone tell me over here very quickly, what type of secretion is the parafollicular cells involved in? What type of secretions will the parafollicular cells release? If the thyroid is releasing thyroid hormone, the parafollicular cells, very good, will release calcitonin, very good, okay? Thank you so much for your quick answers in the chat box. I really appreciate that. Now, the parafollicular cells are something that will be derived from the fourth pharyngeal pouch. This is not something which you need to learn right now. I will talk about this in future in biology, and I'll tell you everything else. But just for remembering purposes, if you can remember that the parafollicular cells are derived from the fourth pharyngeal pouch, then that should be enough. Okay, so till now, that's all we have learned from the first page over here from endocrine and biology. One more time, the questions that you guys will receive from over here is 1, this, 2, 3, 4, 5, 6, and 6, I would say. You will receive 6 questions. And also, this is also a question, but this will be tested in biology more than it will be tested in endocrinology. So that's it. These are the 6 questions. Over here, there's one more thing that I want to talk about from this diagram over here very quickly. As you can see that we have the blood supply of the thyroid gland. So there are 2 things that I want you to understand over here, that we have 2 types of artery supply. We have a superior thyroid artery supply, then we have an inferior thyroid artery supply. The superior thyroid artery is basically a branch of the external carotid artery. So please underline this, put a star. As a matter of fact, I'm going to use my blue cursor for this because this has not been tested, but I feel that there's a potential this will be tested in the future. Okay. And the next one is an inferior thyroid artery. Inferior thyroid artery, as you can see, is a direct branch of the left subclavian artery. This has not been tested, but still has the potential to be tested in the future. So that's it. And can anyone tell me over here, what is this artery called? This inverted arch-like artery. What is this artery called over here? Very quickly, very good. Arch of aorta. Okay. Can anyone unmute themselves and tell me the branches of the arches of the aorta? Can anyone tell me the arch of the aorta? If you can, please write me in the chat box. Me as in M-E. If you are confident, then you can tell me the names of the arches. It's very simple. Can anyone tell me the names of the branches of the arch of the aorta? Anyone? Okay, Dr. Ethar, thank you so much. You can unmute yourself and tell me the names of the branches of the arch of the aorta.
The left subclavian, the brachiocephalic, and the
left subclavian. Very good. So we have left subclavian, brachiocephalic, and carotid. Okay, good. Now, quick question over here, Dr. Ethar. If I were to ask you the branches of brachiocephalic, what are the branches of brachiocephalic? Can anyone tell me the branches of the brachiocephalic?
The right carotid and the right subclavian.
Very good, thank you so much. So we have right subclavian and right carotid. So over here, we have talked about the arches of the aorta, which is not related to endocrinology, but just a quick sort of a recapitulation of what we have studied in the past in our bachelor's. And over here, we have the 2 more informations of the arteries of the thyroid. So with that being said, we are done with endocrinology, embryology. Does anyone have any questions for me from embryology, endocrinology from first day 2021 before I begin endocrine anatomy? Does anyone have any questions? Yes or no? Does anyone have any questions? Yes or no? Okay, no questions? Okay, good. Now, so can we move on to the second page over here, endocrine anatomy? Yes, okay. Is everyone ready to begin endocrine anatomy? If you guys are, can I get a yes in the chat box, please? Okay, good. Yeah. So let's begin with endocrine anatomy. So we're done with this one over here. Have you guys understood what the types of questions, how many questions that will be structured from this small text over here? Yes or no? Have you guys understood and underlined with your red cursor? Okay, good. Now let's begin with endocrine anatomy. Now, when we talk about endocrine anatomy, then we have to talk about basically the master gland first, that is the pituitary gland. Now, the pituitary gland sits in the cranium. The location is what we call as ST. Can anyone tell me the full abbreviation of ST? Does anyone know? ST stands for what? ST stands for sella turcica. Very good. Okay, ST stands for sella turcica. So the pituitary gland, it sits. Basically, we have this sort of a pouch. In this pouch, this is the ST pouch or the sella turcica, where the gland will sort of sit like this, right? And from this gland, we have basically two types of pituitary, depending on their location. One is situated anteriorly, that we call as the adenohypophysis or the anterior pituitary. Another one is called the posterior pituitary or the neurohypophysis. Now, when we talk about the anterior pituitary or the adenohypophysis, we have to talk about the fact that it's involved in the secretion of some of the major hormones of our body. Now, the pituitary gland, before I talk about this, let me talk about something over here very quickly. When we talk about the pituitary gland, I want you guys to understand that the gland itself does not secrete the hormones. What the gland does is the gland is always in a homeostatic environment with the hypothalamus. So if we have the hypothalamic pituitary, and let's talk about the adrenal axis, then are we aware that the first response for the pituitary to release its hormone will come from where? Will come from the hypothalamus. Then the pituitary gland will secrete another hormone that will stimulate the release of the hormones from the adrenal gland, for example. Now, if there's excessive secretion from the adrenal gland, then will there be negative feedback? Yes or no? Will there be a negative feedback on the hypothalamus and the pituitary? Yes. So this is a very basic piece of information. I'm pretty sure you guys are all aware of this. Just wanted to remind you guys over here very quickly that the pituitary gland itself does not decide if it will release the hormone. It is under the influence of the hypothalamus. So if we do have to talk about the master gland, then the master of the master gland is the hypothalamus. So that's it. Now, let's come back to our text over here. That's something that I wanted to talk about. Now, the anterior pituitary is responsible for the release of FSH, LH, ACTH, TSH, prolactin. Now, these are actually tested in your step 1 exam, but I'm pretty sure you guys will already know which hormones are secreted from the anterior pituitary, because only 2 hormones are secreted from the posterior pituitary. So the rest will obviously be secreted from the anterior pituitary. So FSH is the follicular stimulating hormone, luteinizing hormone, adrenocorticotropin, and adrenocorticothyrotropic releasing hormone, thyroid stimulating hormone, prolactin, growth hormone, beta endorphin, and melanotropin, or MSH, as we call as melanotropin stimulating hormone. These are all secreted from the intermediate lobe of the pituitary. This is not tested, so you do not have to know which lobe is involved in the secretion of the hormone. Underline the names of the hormones. That's that. Now, before I talk about the development over here, let me just talk about something very quickly that is extremely, extremely high yield for your step 1 exam. That is POMC, or what we say as pro-opiomelanocortin. So before we do that, let me just talk about this, that the pituitary gland is basically the master gland. Over there, we have a group of cells. This group of cells is what we call as POMC. POMC is POMC. POMC is extremely important for your step 1 exam. POMC is pro-opiomelanocortin. It is involved in the secretion of what we call as BAM, B-A-M, okay? BAM. BAM stands for B for beta endorphin, A for ACTH, M for MSH. Now, why is this high yield? This is high yield because of these two things. Now, over here, let's talk about this very quickly. Can anyone tell me the name or what happens when an adrenal gland, right? When the adrenal gland stops secreting hormone. There is no hormone secretion from the adrenal gland. What is the name of this condition over here? Very quickly. What is this called when the adrenal gland stops producing hormone? What is the name of this condition? Can I get some quick answers in the chat box, please? Does anyone know? Very good. It's very simple. It's called adrenal insufficiency, or what we try to say is adrenocortical insufficiency. Yes or no? This is called adrenocortical insufficiency. Why do we call this as adrenocortical insufficiency? Because we would like to be specific. Yes or no? Because the adrenal gland has two regions, cortex and the medulla. The cortex is responsible for the secretion of the hormones of the zona glomerulosa, zona reticularis, right, and the zona fasciculata. The adrenal medulla is responsible for the secretion of the epinephrines, norepinephrines, and all of those things. Are we aware of this piece of information? Yes or no? That the adrenal gland has two parts, cortex and the medulla. The cortex is responsible for the secretion of GFR, zona glomerulosa, fasciculata reticularis, and the medulla is responsible for the secretion of epinephrine, norepinephrine. So that's that. Now, we would like to be specific when we would say that adrenocortical insufficiency is the name where the adrenal gland stops secreting the hormones. Now, the primary reason for this in Western world or in US is what? Can anyone tell me the primary reason for primary adrenocortical insufficiency in Western world? This is AI. AI stands for what? AI stands for, does it stand for artificial intelligence? Yes or no? AI, what does AI stand for? No, it does not stand for artificial intelligence. Very good. It stands for autoimmune. Very good. So autoimmune. Autoimmune is basically when your own immune system starts attacking your cells. So when your immune system will attack your adrenals, then you will have cessation or decreased secretion of the adrenocortical hormones. So autoimmune in the Western world is the #1 cause. In developing worlds, for example, in some parts of Southeast Asia and all of those regions, we have primary adrenal insufficiency due to tuberculosis. This is extremely important. Is everyone clear? Yes or no? The two reasons why we can have adrenocortical insufficiency in the developing world and in developed world. In the developed world, tuberculosis is not very prevalent. So the primary cause is autoimmune. The secondary, and the second reason for adrenocortical insufficiency in a developing world is tuberculosis. So that's it. Now, the reason why I'm talking about this is whenever we have decreased secretions of the adrenocortical hormones, then what happens is we talked about the hypothalamo-pituitary axis over here. So we talked about the feedbacks. The hypothalamus will stimulate the pituitary will stimulate the adrenals, and the adrenals will have a negative feedback over here and over here. Now, if the adrenocorticotropin releasing hormone secretion is decreased, then will there be a negative feedback or a positive feedback on the hypothalamus? Fast answers, please. Meaning, will the hypothalamus stimulate the pituitary more or stimulate the pituitary less? Fast answers, please. If there is, very good, okay. So meaning that the hypothalamus will stimulate the pituitary gland more. If the hypothalamus stimulates the pituitary gland, the hypothalamus stimulates the gland by releasing corticotropin releasing hormone. This corticotropin releasing hormone will directly go and stimulate the pituitary gland, and specifically they will stimulate the POMC, pro-opiomelanocortin. When they stimulate the pro-opiomelanocortin, will the ACTH be released by itself, or will it be released, with the combination of beta endorphin, ACTH, and MSH? Which one? Can anyone tell me? Will it be released by itself, or will it be released with the combination of beta endorphin, ACTH, and MSH? Very good combination. So does this mean that when CRH is stimulating pituitary gland, in order for us to get ACTH, we will also get MSH? Yes or no? Yes or no? And the answer is yes, very good. And whenever we have excess of MSH, or melanotropin stimulating hormone, do we have excess formation of melanin? Yes or no? Do we have excess formation of melanin? Yes. So does that mean that a patient of adrenocortical insufficiency will have what we call as hyperpigmentation? Hyperpigmentation, darkening of skin, especially also the darkening of skins, and we can appreciate the pigmentation more in gums. We can see the pigmentations in gums. So that's that. Okay. So that's basically what I'm trying to say over here. This is extremely, extremely important for your step 1 exam. Please try to understand that your patient, if there is a patient who comes to you with, let's say he comes to you with the hypotension, right? And then electrolytic imbalance, weight loss, appetite disturbance, salt craving nature, right? And you see that the patient has hyperpigmentation. What is the first diagnosis that should come to your mind? Quick answers, please. What is the first diagnosis that should come to your mind if you see a patient of hypotension, salt craving nature, electrolytic imbalance? The first diagnosis that should come to your mind is adrenal insufficiency. Very good. Okay, adrenocortical insufficiency. That's it. And if anyone asks you why do patients of adrenocortical insufficiency have hyperpigmentation, then what is the answer? The answer is that you have the hypothalamus that will be secreting CRH that will stimulate the pituitary to release BAM, beta endorphin, ACTH, and MSH. And these 3 hormones will be secreted at the same time. As a result, we will have darkening of the skin. Very simple. Let's move on to the next one. We have 2 types of cells. So we're done with POMC. Now let's talk about basophils and acidophils. Basophils are responsible for the secretion of B flat, that is FSH, LH, SATH, TSH. It's not been tested in the step 1 exam as of yet, but I feel like there's a possibility that will be tested. So please use your blue marker for this. And acidophils are responsible for the secretion of prolactin releasing hormone and growth hormone. So that's it. Okay. So please underline this over here very quickly. Okay. Is everyone clear? Yes or no? Okay, good. Now, let's talk about anterior pituitary and where it's developed from. It's basically developed from the oral ectoderm, or what we say as the Rathke pouch. Okay. Use your red marker for this. It's extremely important that you know and you remember that the anterior pituitary is developed from the ectoderm, not the endoderm, because the thyroid is developed from the endoderm. The pituitary gland is developed from the ectoderm, and especially the ectoderm of the oral region, which we call as the Rathke pouch. So please underline this one. And we have 2 types of subunit in the anterior pituitary. We have the alpha subunit, and then we have the beta subunit. The alpha subunit is responsible for the secretion of the hormones, and the beta subunit will determine the hormone specificity. It's not high yield, it's not important. So let's move on to the next one. Let's move on to posterior pituitary. Now, the pituitary gland itself will produce and secrete the hormone. Can anyone tell me if the posterior pituitary will also produce hormones, or will it only secrete hormone? Fast answers, please. The posterior pituitary. Will it produce, or will, very good. It will only secrete the hormone, meaning that the hormones are pre-produced, right? The hormones, they are pre-produced. Can anyone tell me who pre-produces these hormones? Is this the pituitary gland, or I mean, is this the anterior pituitary gland or the hypothalamus? The answer is over here. Yes, it's produced by the hypothalamus. Very good. So the hypothalamus is responsible for the production of the hormones. In the hypothalamus, we have a lot of different types of nucleus. Yes, we have supraoptic and the paraventricular nucleus, which are two of the 6 high-yield nucleus of the hypothalamus, which we will study in the central nervous system. We have the anterior nucleus, posterior nucleus. We have the ventromedial, lateral, supraoptic, paraventricular, and these are the six high-yield nuclei of the hypothalamus. Out of this, for now, all you have to remember is the hypothalamus has supraoptic and paraventricular nuclei, which is responsible for the production of the hormones. Once they are produced, they are released via the posterior pituitary with the help of some carrier proteins, which we call as neurophycins, extremely high yield, meaning that the hormones, they are not secreted by itself, they are secreted with the help of a carrier protein. The carrier protein is called what we call as a neurophycin. It's a globulin containing protein. It's a globulin, meaning that we have different sorts of proteins in our body, but the neurophycins are basically globulin containing protein. So that's it. So this will be tested in your step 1 exam 100%. And also the posterior pituitary is also developed from the ectoderm. So that's another thing. So that's that. These are all the questions that will be structured from this small text over here. Let's move on to the next portion. Let's talk about the adrenal cortex. We're done with the pituitary gland. Let's talk about the adrenal glands. Now, adrenal glands or the suprarenal glands, they basically look like a cluster of fat cells or fat globules on the superior surface of the renals or the superior surface of the bilateral kidneys. Now, when we dissect the adrenal glands, we basically see that there are 2 portions to the glands, as I have said before. We have the cortex, then we have the medulla. Now, I'm pretty sure you guys are all aware that the cortex is divided into GFR, yes or no, zona glomerulosa, fasciculata, reticularis. Is this new information for all of us, yes or no, or is this information we know from before? Can I get some answers in the chat box? Is this information we know from before, yes or no? Do we know this, or is this completely new? Very good. This is information that we have known from before. So the adrenal cortex, we have zona glomerulosa, fasciculata, reticularis. Now, what I need you to understand over here is that when I say zona glomerulosa, fasciculata, and reticularis, what do I mean? What I'm trying to say over here is that the zona glomerulosa, when I say this, if you guys have to identify in histology in your step 1 exam, how do you know that which layer is what? Now, first and foremost, let's talk about the 3 layers. Zona glomerulosa, fasciculata, reticularis. On top of all of this layer, we have this yellow portion, right? Can anyone tell me what is this yellow portion? This yellow portion is what? It's fat, right? This is fat. Okay, good. Then the next layer that comes is the zona glomerulosa. Now the zona glomerulosa, how will it look like? It will look like small glomerular bodies like this. That's why the name is given as zona glomerulosa, because it deposits or it looks like the glomerular capillaries. So zona glomerulosa. Now the next portion is zona fasciculata. Why is this called fasciculata? Because it looks as fasciculations or striations of muscle fibers. So basically they would look something like this, striated vertical sort of lines, right? Striated vertical lines like this. The next portion is zona reticularis. Why is it called reticularis? Because the fibers are arranged in a reticular pattern. What does that mean? Meaning that they are arranged in a horizontal pattern like this. Okay, so this is the easiest way you can identify this in your step 1 exam, because there are questions on how or which layer is involved in the secretion of which hormone, and you have to identify this by looking at the picture. So when you look at the picture, and I do not want you guys to get confused, which layer is what? So very simple, try to remember that zona glomerulosa will have round cells, which looks like glomeruli. Fasciculata will have vertical cells, and reticularis will have horizontal cells or horizontal pattern. Is everyone clear? Yes or no? Is everyone clear? Yes? Okay, very simple. It's very simple. Now, another thing that I want to talk about over here very quickly, that over here, you have G, you have F, you have R, GFR, meaning you have zona glomerulosa, fasciculata, reticularis. The zona glomerulosa will secrete what? Can anyone tell me what will the zona glomerulosa secrete? It will secrete, fast answers please, it will secrete aldosterone, very good, or what we call as mineralocorticoids, meaning that it will conduct the sodium potassium channels and the hydrogen potassium channels. So that's that, aldosterone. The next thing is the fasciculata. The fasciculata will secrete what? Can anyone tell me? They will secrete cortisol, or what we call as glucocorticoids, meaning that they will maintain our blood glucose levels, and they are released in the period of stress when we go through physical stress, for example, during surgery, during recovery, during cancer or any sort of disease, infection, then we have secretion of cortisol level. So that's that. And then we have reticularis. They are responsible for the secretion of what? Androgens, very good. We have androgens such as dihydroxyepiandrosterone, androstenedione, and these are some of the adrenal androgens. If they are secreted in high amount, then patients will get viralizations, and we will talk about this in details very quickly. Now, the reason why I'm talking about this over here is in order for these layers to secrete these hormones, they have to be stimulated by the pituitary gland. Yes or no? They have to be stimulated by the pituitary gland. Can anyone tell me which layer does not need to be stimulated by the pituitary glands in order to release the hormone? Fast answers, please. Which layer? Very good, glomerulosa. Why? Because the glomerulosa depends on the stimulation of which one? Angiotensin 2. Or Dr. Ethar has said RAS system. RAS stands for renin angiotensin aldosterone system, one of the most important systems of the human homeostatic environment. So that's that. Now, next question. If there is a pituitary mass, a hormone producing anterior pituitary mass, over here we have aldosterone, cortisol, androgens. Will the aldosterone level be high or will it be low? Or will it, which one? If there's an anterior pituitary hormone releasing tumor. Will the aldosterone be high or low? Or will the aldosterone be unaffected? Which one? It will be unaffected. Okay, it will be unaffected. What would happen to the cortisol? High or low? High. What would happen to androgens? High or low? High. Very good. Okay, very good. So, are you guys trying to say that the ACTH will only stimulate cortisol and androgen levels? Yes or no? Is this what you're trying to say over here? The answer is yes. Very simple. And a lot of physicians and a lot of matured physicians still to this day make this mistake. They believe ACTH will also stimulate the zona glomerulosa, but this is a very common mistake which we all make. So please refrain from making this mistake in your step 1 exam. In your step 1 exam, they will test this time and time again to see if you are aware that angiotensin 2 will stimulate the zona glomerulosa and aldosterone will secrete after being stimulated by angiotensin 2. So that's what I was trying to say over here. Let's go back to our text. Then the next one is the medulla. The medulla contains cells called the chromaffin cells. The chromaffin cells, they are regulated by the preganglionic sympathetic fibers that will release catecholamines, or what we call as epinephrines or norepinephrine. So that's that. Can anyone tell me the name of an adrenal medullary tumor? Exceptionally high yield. We find this in multiple endocrine neoplasia. What is the name of the adrenal medullary tumor in which we have excessive secretion of epinephrine, norepinephrine? The name of the tumor is, fast answers please, adrenal medullary tumor that is responsible for the secretion of epinephrine, norepinephrine. The name of the tumor is pheochromocytoma. Very good. It's called pheochromocytoma. Okay, so that's it. Now, that's all we need to know from over here. Please remember that this will be tested in your step 1 exam. They will test you on the histology. They will test you on the regulation. Okay, so that's that. Now, let's move on to the pancreas, the endocrine pancreas. The pancreas, that's called the islet of Langerhans. And over here, we have 3 types of cells. We have alpha, beta, and the delta cells, right? The islets, the alpha is responsible for the secretion of glucagon, extremely high yield. This will be tested in your step 1 exam. Beta cells will secrete insulin, extremely high yield. And delta cell will secrete somatostatin. Okay, sometimes we can get tumors of alpha cells where we can get glucagonoma. We have tumors of beta cells where we can have insulinoma. We have tumors of delta cells where we can have somatostatinoma. So that's it. Another thing that I feel that there's a potential that will be tested in the future exam is over here. If I have to ask you, we have the head of the pancreas, body, and the tail of the pancreas. Can anyone tell me where we have the most amount of beta cells? Where is the most amount of beta cell? Head, body, or tail? Tail. Does everyone approve tail? Yes or no? Head, body, and tail. Does everyone approve the tail of the pancreas, as Dr. Salman has just said in the chat box? The answer is yes. Okay, so very good, Dr. Salman, you are absolutely correct. The tail of the pancreas is high in beta cells, and that's it. So if we have any tumor of the tail in the tail of the pancreas, especially arising from the pancreas, can we have excess amount of insulin? Yes or no? Insulinomas? Yes, okay, good. So that's it. So with that being said, we're done with endocrine anatomy. Are you guys, have you guys understood and have you guys completed your underlinings with the red cursor, yes or no, or with your red pen? Okay, good. Have you guys understood what type of question will be structured from this text over here, from this page over here, yes or no? Best answers, please. Okay. Is everyone clear? Can I move on to the next page? Does anyone have any questions for me? Does anyone have any questions? Yes or no? Okay. No. Okay, good. Can we move on to this page right now? Is everyone ready? Okay, good. Now, let's begin with hypothalamic pituitary hormones. Okay, let's begin with hypothalamic pituitary hormones. The hypothalamic pituitary hormones, let's begin with this. Now, what sort of hormones will be secreted from basically the hypothalamus and, and the pituitary gland, and what are their functions, and what are the clinical incidents where these hormones can increase or decrease? So let's talk about this. Let's talk about the first one, that is antidiuretic hormone. Can anyone tell me where is the ADH secreted from? Fast answers, please. Anterior pituitary or posterior pituitary? The answer is it's secreted from the posterior pituitary. Who produces ADH, hypothalamus or the pituitary gland? Fast answers, please. It is produced by the hypothalamus. Very good. Okay. Now, ADH, what it does is, first and foremost, antidiuretic hormones. ADH will increase the water permeability of the distal convoluted tubules and collecting duct, meaning that antidiuretic hormone will allow excessive absorption of water from the glomeruli. So let's talk about this over here very quickly. Let me just get a page. Meaning that over here, what do we mean? We mean that whenever we have water moving through the glomeruli or the tops of capillaries, right? The ADH will basically work in this portion, distal convoluted tubule, and the collecting ducts. What they will do is they will create channels, right? These channels are what we call as aquaporins. Yes or no? Aquaporins, they will increase the movement of water from the from this region of the glomerular capillaries, and they will enter into your bloodstream. So can anyone tell me if there's excessive secretion of ADH, will we produce concentrated urine or will we produce dilute urine? Which one? Excessive ADH secretion. The answer is very good. We will produce concentrated urine because excess amount of water will get absorbed by the aquaporins under the stimulation of ADH in distal convoluted tubule and collecting duct. So that's what I'm trying to say over here. Now, why do we have excessive secretion of ADH? Now, ADH normally or physiologically will only be released under the influence of what? Why will hypothalamus suddenly start releasing ADH? Why? Can the stimulus be plasma osmolarity? Yes or no? We already have Dr. Salman who wrote the answer. The answer is very good. Plasma osmolarity, meaning that if our blood or the plasma becomes hyperosmolar, can anyone tell me the normal osmolarity of the blood? Is the normal osmolarity of the blood around 295 to what? Can anyone tell me the range of the osmolarity of the blood? Closely to 295 to 305 or 315, and anything above 315 will be considered as hyperosmolar. So if we have high amount of plasma osmolarity, will the hypothalamus secrete the ADH? Yes or no? Fast answers, please. The answer is yes. Okay. So if we have a high amount of plasma osmolarity, the hypothalamus will secrete ADH, and this will maintain our normal osmolar balance. Now, another thing is ADH can also be secreted in a pathological form where we call this as SIAD or SIADH or syndrome of inappropriate ADH hormone secretion. One of the major reasons for SIADH is, can anyone tell me the major reason of SIADH being secreted is for USMLE step 1, we have lung cancer. Can anyone tell me what type of lung cancer? Small cell lung cancer or squamous cell carcinoma? Very good. We already have the answer. Small cell. Okay, so small cell ectopic ADH secretion. Very good. Can also ADH be secreted in terms of lung infections or pneumonias? Yes or no? Or fibrosis, bronchiectasis, and these conditions? Yes or no? The answer is yes. Okay. That when we have lung infections or we have any sort of lung pathologies, then sometimes these will stimulate the hypothalamus to secrete excessive form of ADH. So that's it. Okay, so that's all we need to know for this one. Let's move on to CRH. Is everyone clear about SIADH? Is everyone clear about SIADH? Yes or no? Okay, good. Let's move on to the next one. Let's move on to CRH. CRH is basically corticotropin releasing hormone. Corticotropin releasing hormone will be secreted from the hypothalamus. And we have already talked about this, that they will stimulate 3 hormones together. That is beta endorphin, ACTH, and MSH. All 3 hormones will be released at the same time. Once again, is this why patients of adrenocortical insufficiency will they be hyperpigmented or hypopigmented? Fast answers, please. They will be hyper or hypo. Fast answers, please. Hyperpigmented. Very good. Okay, so that's it. Is everyone clear why they're hyperpigmented? The answer is yes or no. Is everyone clear? If not, I will repeat myself. I will tell you one more time because it's important for your exam. Okay, good. So everyone's clear. Now, clinical notes, sometimes CRH secretion will decrease in secondary adrenocortical insufficiency, or what we call is if someone is using steroid for a long period of time. If someone is using steroid or corticosteroid for a long period of time, can the exogenous entry of the corticosteroid have a negative feedback on the hypothalamus? Yes or no? Exogenous, yes. If it does, will there be excessive secretion of CRH or decreased secretion of CRH? Fast answer, please. There will be excessive or decreased secretion. Now, very quickly over here, what are the types of patients who will use exogenous or chronic steroids? Number one is RA, meaning patients of rheumatoid arthritis, patients of SLE, or any other autoimmune diseases. Yes. So for your step one exam, these are some of the most high yield. Then we also have another one, but over there, we do not use it for a long period of time, but that is sarcoidosis. In sarcoidosis, we use it for a short period of time or not at all. But for your step one exam, I would highly, highly advise, if you guys can remember, rheumatoid arthritis and SLE. Rheumatoid arthritis and SLE, these patients will use use steroids for a long period of time. As a result, they will have decreased secretion of CRH. So that's it. Next one is dopamine. Dopamine is responsible for decreasing the secretion of two things, that is prolactin and TSH. Dopamine is also called prolactin inhibiting factor, or PIF. Now, very quickly over here, dopamine, if we have, can anyone tell me what is the most common pituitary tumor? What is the most common pituitary tumor? Anyone? Does anyone know what is the most common pituitary tumor? Very good. It's a prolactinoma. Okay, good. So if it's a okay, very good. It's good. It's called a lactotrophic adenoma or a prolactinoma over there. Very good. Now the question is, if we have excessive secretion of prolactin from the prolactinoma, do we prescribe patients of small prolactinomas with dopamine agonistic drugs, yes or no? Such as bromocriptine or cabergoline? Yes? No. If the tumor size or the size of the prolactinoma is small, then sometimes we would like to prescribe our patients with dopamine agonists or bromocriptines or cabergolines. Now, these things, what they will do is they will decrease prolactin, and sometimes they will also stimulate TSH. So does that mean that patients who are under the influence of dopamine agonist can have excessive secretion of TSH? Yes or no? Yes. Okay. So that's that. This is exceptionally high yield for your step one exam, that patients of prolactinoma, small prolactinomas, the size is not important for your step one exam. For step two CK exam, I would like to talk about the size of the step two CK class, and for the step one class, you don't need to know about the size. Just try to remember that the prolactin, if there's excessive secretion of prolactin from a prolactinoma, if it's small, then we would like to prescribe our patients with dopamine agonists, such as bromocriptine or cabergoline, that will decrease the secretion of prolactin hormone. So that's that. Now, another thing that I would like to talk about is some patients are treated with anti-dopaminic drugs. Now, these patients are patients of psychiatry, yes or no? Psyche patients, for example, schizophrenia and psychotic disorders, yes or no? Do we give them antipsychotics? The answer is yes. Now, if I have to talk about psychosis, then one of the major reasons why we have psychosis and the positive symptoms of psychosis, that is hallucination, delusion, then we have your grandiose behavior, and all of those things are basically the result of excessive amount of dopamine secretion. If there's an excessive amount of dopamine secretion in your mesolimbic, mesocortical pathways, then you can have the positive symptoms. So for antipsychosis, we would like to block the secretion of dopamine and treat our patients. But when we block our patients or when we give antipsychotics, are we also increasing the prolactin level? Yes or no? The answer is yes. So what I'm trying to say over here is that the number one side effect of antipsychotics sometimes is excessive amount of prolactins. Okay, excessive amount of prolactins, and this excessive amount of prolactin can sometimes cause galactorrhea, and that's basically it. That's what I want you guys to remember. Please put your star mark over here. That's that. Let's move on to the next one. That is growth hormone releasing hormone. Growth hormone releasing hormone is secreted from the hypothalamus. They will stimulate the pituitary to release excessive amount of growth hormone. The analog for a growth hormone releasing hormone is tesamorelin. It's not tested in your step 1 exam. I'm going to use my blue cursor for this one. And this hormone will be used to treat HIV-associated lipodystrophy. It's not high yield. It's not tested in your exam as of yet. So you can use your blue marker to sort of underline this for a potential question in the future, but that's it. Let's move on to the next one. That is GnRH, or gonadotropin releasing hormone. This is once again released. The GnRH is basically released from the hypothalamus. They will stimulate the pituitary gland to release FSH and LH, follicular stimulating hormone, and the luteinizing hormone that will work in the ovaries and testicles to secrete the androgenic hormones. So that's that. So that's basically what we are talking about. But there's one thing that we have to understand is when we have high amount of prolactin secretion in our blood, we can have decrease of FSH, LH, and GnRH. So for example, let's say that we have a 38-year-old woman who comes to you with absence of menstruation for a long period of time. Along with that, the patient has had complaints of secretion from the mammary glands. What is the next best test, or what is the next thing that you will think about in this patient as the reason for the absence of menstruation? Can anyone tell me the answer? What can be the answer for this patient who has a sudden onset of abrupt cessation of menstruation? Very good, pituitary adenoma. So what would you do? Should you do CT imaging, MRI? Very good. Okay, so you should do some sort of an imaging. It could be CT scan, it could be an MRI. And once you do that, then we can think about if the patient is suffering from a prolactinoma or not. So that's that. So try to remember that hyperprolactinemia or increased amount of prolactin will decrease your FSH-LH. So that's it. We also use GnRH analogs such as leuprolide to sort of suppress the hypothalamo-pituitary gonadal axis. Now, we use this in 2 ways. Okay, this is something which I want you guys to understand very quickly over here. Okay, just give me 1 second. Now, what you guys need to understand over here is that we have the hypothalamus once again. We have the pituitary, and then we have the glands, right? And right now, this is your either it's the ovary or either it's the testicle. Now, the thing is I want to talk about is when we stimulate the hypothalamus, there are 2 ways we can stimulate the hypothalamus. One is a tonic. One is tonic, another one is pulsatile. Pulsatile means that we use slow amounts of GnRH every day. And tonic means you abruptly give a lot of GnRH at the same time. Now, the way in which we use the GnRH will affect our FSH and LH. If we use tonic, then there will be abrupt cessation of FSH, LH. If we use pulsatile, then there will be increased secretion of FSH, LH. So if we want to promote fertility, should we use in a tonic fashion or in a pulsatile fashion? Fast answers, please. Very good. Okay. And if we want to decrease the secretion of FSH and LH, should we use this in a tonic fashion or in a pulsatile fashion? tonic fashion. Very well. So these are questions from your step 1 exam, which we have discussed. Put your star mark over here. You will be tested on this. Let's move on to the next one. Let's move on to MSH, or melanotropin stimulating hormone. Your melanotropin stimulating hormone is something that we have already talked about. That is, they will increase melanogenesis, or increase formation of melanin. Melanin is basically the pigment that makes our skin dark. So patients with Cushing's disease, or what do we mean by Cushing's disease? Cushing's disease is basically the disease where the pituitary gland is responsible for secretion, or for secreting excessive amount of ACTH. So that's that, Cushing's disease. So they will be secreting BAM. Once again, just want to keep on saying BAM from time to time so that you guys can remember this. This stands for beta endorphin, ACTH, and MSH. They will be secreted at the same time. And if you ask me why, the answer is because, once again, they have a similar genesis, meaning that they will all be secreted from the pro or pyomelanocortin. So that's that. Okay, let's move on to the next one, that is oxytocin. What is oxytocin used for? Oxytocin is used for two things over here. One is uterine contraction during labors. So if there is a prolonged labor, or if we want to make sure that the labor progresses smoothly, then on the onset of labor pain, sometimes we would like to give our patients oxytocin to promote uterine contractions. And also it's responsible for the contraction of the myoepithelial cells in your mammary glands. So if there's a baby who is if there's a baby who is suckling on the mammary glands of the mother, then we have the stimulation of the hypothalamus. The hypothalamus will secrete oxytocin. The oxytocin will go and directly stimulate the myoepithelial cells. The myoepithelial cells will contract, and we will have the release of the breast milk. So that's that. Oxytocin in psychosocial form has some other clinical criteria. They can sometimes modulate, or meaning that they can cause fear, anxiety. They will also increase social bonding. So I'm not going to use my red cursor for this because these are not questions. These two are questions. Okay, so that's it. That's all we need to know about oxytocin. Let's move on to prolactin. Once again, high amount of prolactin will increase TSH. My apologies. High amount of prolactin, once again, my apologies, high amount of prolactin will decrease TSH and GnRH. Okay, so that's that. If there is excessive amount of prolactin, meaning that if it's a prolactinoma, they will suppress all the other cells of the anterior pituitary, and this will decrease TSH, GnRH, and all of those things. So that's that. And if it produces hormones, then we can have prolactinomas. The signs, symptoms of prolactinomas are a very, very high yield. Let me talk about this over here very quickly. First and foremost, let's talk about this. Is everyone understanding the lecture? Yes or no? Before I talk about prolactinoma, is everyone understanding the lecture? Yes or no? Does anyone have any questions for me? Okay, good. Okay, I know you guys are a little bit tired because I've been talking for the last 1 hour. I will give you guys a break over here very quickly for 10 minutes. Before I do that, can we finish prolactinoma? Yes or no? Can we finish prolactinoma? Okay. Okay. Dopamine and TSH, I'll talk about it in 1 second. Before I do that, let me talk about prolactinoma. First and foremost, prolactinoma is an anterior pituitary tumor. If it's an anterior pituitary tumor, what are some of the signs and symptoms the patients will complain about? Number one, if it's a CNS tumor, regardless, patients will complain of some general sign symptoms. That is early morning headache. Always remember this. These headaches are early morning headache associated with heaviness and vomiting. Okay, then next thing, prolactinoma, patients will complain of either blurry visions or diplopia or loss of peripheral vision. If you ask me why, then the answer is very simple. That is, prolactinoma will suppress or push on the OC. What is the OC? Quick answers, please. OC stands for optic, what? Optic chiasm, yes or no? Very good, thank you so much. Optic chiasm, you know the optic chiasm that goes like this, and then we have the tumor over here. So that's it, okay? So optic chiasm. Signs, what are some of the signs that we can see over here? These are some of the symptoms. Signs which we can see, number one is if we would like to inspect the eyes, then we would see that the patients have a very high yield sign, that is papilloedema, right? Then patients will have signs, symptoms of adrenocortical insufficiency and insufficiencies of all the other major hormones. That is, they will have hypothyroidism and all of those things. So these are some of the signs. Now, let's talk about specific sign symptoms specific to cholecystoma. Not only will the patients have early morning headache, vomiting, loss of peripheral vision, papilloedema, sign symptoms of hypothyroidism and adrenocortical insufficiency, some of the major signs that they will have is, number one, they will have, if it's a female patient, they will have amenorrhea. Amenorrhea basically means absence of menstruation. They will have osteoporosis. Why will they have osteoporosis? Because of decreased estrogen. Please remember this. Estrogen will decrease. As a result, there will be early onset of osteoporosis. Another thing that they will have is they will have galactorrhea, meaning that excessive secretion of or secretion from the mammary gland or breast milk secretion. So that's it. Okay. So that's what I'm trying to talk about over here. So very quickly underline this: amenorrhea, osteoporosis, and osteoporosis by here, please write down the reason is because of decreased estrogen. Very, very, very common in female patients, hypogonadism and galactorrhea. So that's it. And that's basically what I'm trying to say over here. Next one is breastfeeding. Breastfeeding physiologically will increase your prolactin level and decrease the GnRH. So patients can have a natural conception for 6 months. Now, this is a step 2 CK question, but I'm just going to ask you guys over here. If a mother is breast milking for or feeding their babies with breast milk for 6 months, are they still, or do they need to use protection? Yes or no? Do they need to use contraception to prevent pregnancy, or is breast milk or breastfeeding enough? The question is breastfeeding enough, or do they need more contraception? Which one is the correct answer? As of 2021, breast milk or breastfeeding is not enough, unfortunately. Okay, breastfeeding by itself is not enough. Patients need more contraception. If you come across a question in your step 1, step 2 CK exam, they're asking you whether if the mother who is already breastfeeding requires extra contraception. If they ask you if it's a yes or a no, the answer is yes, they need extra contraception. What type of contraception will they be using during their period of breastfeeding? The answer is very good. It's POPs or progesterone only pills. Are we going to use IUDs? Yes or no? Intrauterine devices. C, or copper containing intrauterine devices? The answer is no, because the uterus needs time to heal. Okay, the uterus, they need time to heal. So if they are going to practice copulation or conception in the period of 6 months, then they need extra contraception. So that's it. Let's move on to the next one, that is somatostatin. Somatostatin is responsible for decreasing the secretion of GH and TSH, meaning that somatostatin analogs can decrease growth hormone. So can we use somatostatin analog to treat conditions such as acromegaly? Yes or no? Excessive secretion of growth hormone? The answer is yes or no? Yes, very good. Okay, so that's it. Now, do we also use somatostatin analogs sometimes to treat conditions of hepatic cirrhosis where patients have variceal bleeding? Yes or no? Do we use somatostatin analog for the treatment of variceal bleeding? Yes or no? Yes, very good. Please write this down over here. Analogs used to treat acromegaly and VB. So VB stands for variceal bleeding. Okay. Can anyone tell me how and why somatostatin decreases variceal bleeding. Okay, so we'll talk about this in the future. Don't worry, we'll talk about variceal bleeding and somatostatin. I do not want you guys to get distracted from your current topic right now. So just try to remember for now that somatostatin will treat acromegaly and variceal bleeding. So that's it. Let's move on to the next one, TRH, thyrotropin releasing hormone. They increase the secretion of TSH and prolactin. So that's basically that, meaning that if we have excessive secretion of thyrotropin releasing hormone, TSH and prolactin will increase together. Patients can sometimes have galactorrhea, meaning that patients of hypothyroidism. Okay, so let's talk about this very quickly for 1 second. We had a student who asked a question about prolactin and TSH, so we'll talk about this over here. TSH and prolactin. What's happening over here is patients of hypothyroid, they have decreased T3, T4, and increased TSH. Yes or no? Fast answers, please. They have increased TSH. The answer is yes or no. Is this correct or not correct? Is this correct or not correct? This is correct. Okay. So what's happening over here? Okay, good. So this is correct. So what's happening over here is the TSH is high because this decreased T3, T4 is directly stimulating your hypothalamus. The hypothalamus is increasing the secretion of TRH. TRH, what it does is it stimulates the anterior pituitary. When it stimulates the anterior pituitary, it stimulates the pituitary gland to release TSH from the same region where prolactin is secreted. Now, my question is, if there is a patient of severe hypothyroidism, will they have increased secretion of TRH? Yes or no? Fast answers, please. The answer is yes. If there's an increased secretion of TRH, will they increasingly stimulate the anterior pituitary? Yes or no? The answer is yes. Okay. If they excessively stimulate the anterior pituitary and they stimulate the region where prolactin is secreted, can we have physiological growth or physiological increase in the size of the prolactin releasing cells? Yes or no? Okay, good. So meaning that patients of hypothyroidism, when they have a decreased amount of thyroid hormone, there is increased amount of thyrotropin releasing hormone from the hypothalamus. They will stimulate the anterior pituitary to release TSH and prolactin together, basically trying to tell you that sometimes some patients of hypothyroidism can have prolactin or physiological prolactinomas. So that's that. Now, these prolactinomas, these physiological prolactinomas, can they be easily treated with dopamine agonists? Yes or no? These physiological prolactinomas, can they be treated easily with dopamine agonists? Yes or no? Last answer, please. The answer is yes. Okay, so that's that. So once we give a high amount of dopamine, what it does is that the dopamine itself will decrease the prolactin secretion. It will decrease the size of the prolactinoma, and dopamine itself will also stimulate TSH a little bit. Okay, so this is your answer to the student who had the question regarding dopamine and TSH. That is, dopamine agonists can also increase your TSH level. Okay, meaning that they can also be used to treat hypothyroidism. So patients of hypothyroidism with prolactinomas, we can give them bromocriptine, cabergoline, along with thyroid hormones. Are we clear? Yes or no, everyone? Are we clear? Yes or no? Okay, good. So some quick questions, quick answers. Is everyone ready for some quick questions, quick answers? Okay. Okay, now, what is the name of the hormone that is responsible for increasing the water permeability of the distal convoluted tubule and the collecting duct? ADH, very good. Which hormone is responsible for the secretion of BAM, beta endorphin, ACTH, and MSH? The answer is CRH, very good. Dopamine, will increase or decrease prolactin? Which one? Dopamine will decrease prolactin. Very good. If we have hyperprolactin, what would happen to the GnRH? Will there be decreased GnRH or increased GnRH? The answer is decreased GnRH. Very good. What is the name of the hormone that will decrease growth hormone? Sometimes we use it to treat acromegaly and racial bleeding. The answer is, name of the hormone is somatostatin. Very good. Next question over here. Zona glomerulosa, fasciculata, reticularis. Which one is responsible to be regulated by angiotensin II? The answer is glomerulosa. Very good. Okay. Next question. Next question is that pro-opiomelanocortin will release 3 types of hormones. What is the name of these 3 hormones? Bam. Very good. Superior thyroid artery is a branch of which artery? Superior thyroid artery is a branch of external carotid. Very good. Inferior thyroid artery is a branch of which artery? It's a branch of left subclavian. Yes, very good. Okay, it's a branch of left subclavian. Next one. Next question. Thyroid is developed from which layer? Ectoderm, mesoderm, endoderm. The answer is endoderm. Very good. A patient comes to you with an anterior midline neck swelling. And what are the 2 differential diagnoses that you will think about for a patient with anterior midline neck swelling for US? The answer is paravessel duct cyst or persistent cervical sinus. Yes or no? You'll think about persistent cervical sinus. Which one will move with protrusion of the tongue? Very good. The first one, yes, very good. Meaning that the paravessel duct cyst. Okay. Okay, so that's about some of the things that we have talked about for the last for the last hour and a half. Okay, has everyone understood the 3 pages, the first 3 pages of endocrinology? Yes, easy or not easy after reading the first aid like this? Is it easier? Yes or no? Easy. Good. Okay, so this is the way, or this is the method in which you guys should be reading your first aid. Always try to remember, USMLE Step 1 exam is not an exam it's not an exam which will test your memory skills or how much you can memorize. Basically, it will try to test your clinical skills, and it will try to test if you can associate the physiological and the pathological findings of basic sciences with the clinical criteria and the clinical scenario. So that's that. You don't need to memorize anything. All you need to do is understand and just remember a little bit of information from here or there. And that's basically that. So with that being said, can we take a break for, let's say, 15 minutes, 10 to 15 minutes? Yes or no? Okay. Yes, but okay. The reason for taking the break is because right now, let me tell you over here very quickly why are we taking a break. The reason why we're taking a break is that these are your neurons, yes or no? Okay, look, these are your neurons. This is 8:30 a.m. where we started the class. At the beginning of the class, your synapses were firing, yes or no? Right. Now, at 10 a.m. right now, all your synapses are depleted of the neurotransmitters. In order to proceed further, do we need replenishment of the neurotransmitters and the preganglionic fibers? Yes or no? So that our synapses will fire more quickly. The answer is yes. Okay, so that's why we need to take breaks. Every 1 to 1.5 hours, we'll take a break for 15 minutes. That's how we will conduct our class in the future. And the answer is simple. Why? Because we want to make sure that our neurons can restore and reproduce the neurotransmitters that we have lost in the last 1 hour. So that's it. Okay, so with that being said, thank you so much. Let's take a break for 15 minutes. I will stop sharing my screen right now. And it's 10:04 a.m. in New York Eastern Time. And we will begin the class in 15 minutes, meaning that we will begin the class at 10:19 a.m. Thank you so much. Please go and rejuvenate and replenish yourself. Drink coffees, water, food, whatever is necessary. And then I'll see you guys in 15 minutes. Thank you so much. Okay, if you guys have questions, please use the chat box. Okay, thank you so much. I'm going to mute myself and I'll see you guys at 10:19. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Okay, good. We have a question from Dr. Adi Rahman. So I'll talk about this. Thank you so much, Dr. Rahman, for your question. I'll answer your question up to the end of the lecture. For now, can I have your attention back on the task? Is everyone back? Can I get a yes from everyone if you guys are back from your break? Okay, go. Very good, very well. What are some of the things that you guys do during the break time? Do you guys drink coffee, food, water? What do you guys do? What are some of the things that you guys do during your break time? Get some fast answers over here. Coffee, water, food, sleep. Food, okay, good. Shake, okay. Talk to mom, good. Talk to mom, very good. It's one of the best things that you can do during your break is talking to your mom, letting them know. Coffee, really good. Tea and sweet, very good. That'd be good. Very well. So from what it sounds like you guys are rejuvenated and replenished, and you guys are ready to begin the third page of endocrinology for growth hormone. And we will begin. Okay, so let's start talking about growth hormone. Okay, very, very high yield, very, very important. And it's a very fun topic to talk about. That is, why do we have secretions of growth hormone? What are the physiological conditions? And what are some of the pathological conditions? Okay, so let's talk about the physiological conditions of why we have excessive secretions of growth hormone. Now, before I talk about this, I'm going to talk about some of the things. I want to talk about our brain, okay, as a whole. Are we aware that our brain survives on three things? What are the three things that our brain survives on? Number one is what? Blood. Very simple. Your brain needs blood. In your blood, what does the brain seek to function? Glucose, protein, fat. The answer is brain survives on supplements or supply of glucose. And what else? Brain needs oxygen for metabolism. Yes or no? So brain needs glucose, brain needs oxygen. So that's that. Now, in periods of stress, if we are stressed out, the number one organ that is affected is your brain, meaning that stress directly affects your brain, whether it's physical stress or any other psychosocial stress which we are suffering from. The brain is the first affected organ. So the body's number one action is to preserve the function of our brain, right? The body's number one action is to preserve the brain, because if the brain lives, then we live, as simple as that. So what the body does is that whenever we undergo certain conditions, for example, stress for that matter, the body releases a couple of hormones, out of which growth hormone is one of those hormones. The body also releases another hormone that is high yield. The body releases cortisol. And what it does is the function of growth hormone and cortisol in respect to maintaining the function of the brain is that it increases your glucose level. Yes or no? It increases your glucose level. How? It increases your glucose level by the process of gluconeogenesis. Okay, what is gluconeogenesis? Gluconeogenesis is basically if there is not enough supply of glucose in your blood, these hormones will break down the protein and fat and convert them and push them in a pathway that can be used for the formation or production of glucose, as simple as that. So that's basically what I'm talking about over here. So physiologically, if I ask you, what are some of the stimulus for the secretion of growth hormone, then the number one thing that I need you to understand is stress. Okay, so number one is stress. Second is we have sleep, we have hypoglycemia. These are some of the physiological stimulants of growth hormone secretion. Once again, do we have excessive secretion or increased secretion of growth hormone if we incorporate ourselves into physical stress? For example, if someone is involved in sports or working out, then do they have increased or decreased secretion of growth hormone? Fast answers, please. They have increased or decreased secretion of growth hormone. Very good. They have increased secretion of growth hormones. Another thing very important that we have to understand for US and Western world is that if we become a physician, which we will come across a lot of patients who abuse growth hormone. Yes or no? Why do patients abuse growth hormone? Patients who abuse growth hormones are your professionals. They are your professional bodybuilders. Yes or no? Professional bodybuilders, professional athletes, they undergo dopings and different sorts of things that what they do is to enhance their performance. They have exogenous growth hormone, right? And they directly affect your glucose level. Patients are more prone to have hyperglycemic conditions, diabetes, cardiomyopathies, and all of those things. So these are some of the pathological conditions where we can have exogenous growth hormone secretion. Another pathological condition where we can have excessive growth hormone secretion is if we have somatotropin releasing, or if we can have a somatotrop or somatographic adenoma or a pituitary growth hormone releasing tumor. So that's it. So sleep, hyperglycemia, stress, and all of these are the physiological conditions. They will directly stimulate your hypothalamus. The hypothalamus will then secrete your growth hormone releasing hormone. They will directly go to your pituitary gland, and the pituitary gland will release growth hormone. These growth hormones, what they will do is they will travel in the blood. Now the question is, will they travel in the blood by themselves, or will they travel in the blood with the help of a carrier protein? The answer is, fast answers please. Will they travel by themselves, or will they travel with the help of a carrier protein? The answer is, does anyone know the answer? Will growth hormone travel by itself, or does growth hormone need a carrier protein to travel? There are no right or wrong answers. There's only participations. If you participate, either you're going to be correct or you will be incorrect. In which ways, in both ways, you will learn. So please try to participate in the class. The answer is not by themselves. Growth hormone will travel with the help of carrier proteins. So that's that. Growth hormones will travel with the help of carrier proteins in the blood. These proteins will take the growth hormones. The blood will circulate in your body. And with the help of these proteins, the hormones will go to different regions. Number one, the hormone will go to your bones. In your bone, the hormone will develop it will help in the development of the entire corticular system of the bone by increasing the amino acid uptake, protein synthesis, DNA, RNA synthesis, collagen, and cell size. Now, the question is, will these be tested in your step 1 exam? The answer is no. Okay, this is just for you to understand the functions of the growth hormone in your body. That's that. Next one is that the growth hormone will then go to another part, that is the skeletal muscles. In the skeletal muscles, the growth hormone will stimulate the muscles to undergo hypertrophy, and they will have increased amount of amino acid and protein synthesis. So that's it. Now, my next very high yield question that will be tested in your step 1 exam is that will growth hormone work directly on the muscle and the bone, or do they need to be converted to IGF? The answer is growth hormone, they need to be converted to IGF. What is IGF? IGF is insulin-like growth factor. It's not insulin, it's insulin-like growth factor. How many of us are aware that insulin is an anabolic hormone? Insulin, is it an anabolic hormone or is it a catabolic hormone? The answer is insulin is an anabolic. Very good. Insulin is an anabolic hormone, meaning that anabolism is basically the process of synthesis. They will allow synthesis to occur in the skeletal muscles and the bones. So that's that. So before growth hormone goes and works in the bone and the muscles, the growth hormones will first go to the liver, where they will be converted to insulin-like growth factor. Another name for insulin-like growth factor is called somatomedin C. So that's that. And then this insulin-like growth factor will go to the bones and the muscles, and they will cause these types of functions. So that's that. I'm pretty sure you guys know this. I just want to talk about one thing over here very quickly. What are some of these stimulus that will prevent growth hormone secretion? The number one reason why you can have decreased growth hormone is if you are obese, meaning that if there is high amount of fat, this fat will prevent growth hormone secretion. So that's that. That's why you see fatty people or obese people, they have a higher fat percentage with low muscle mass. Why do they have low muscle mass? Because the fat is basically inhibiting the release of the growth hormone and inhibiting the stimulations of the muscles and the bone. So that's that. Next one is glucose. High amount of glucose, or patients who are always hyperglycemic, such as diabetic patients. These patients can have decreased secretions of growth hormone. So that's that. So I'm just going to write DM so that you guys can remember that these are some of the stimulus. Now let's read the text over here very quickly and try to identify the questions. First of all, growth hormone is also called somatotropin. It's secreted by the anti-pituitary. We know this. It stimulates the linear growth and muscle mass through IGF-1. This is a question for your step 1 exam that they do not work by themselves. They work by after being converted to IGF-1. They can increase your insulin resistance, meaning that the IGF-1, if there's high amount of growth hormone, as I have said from before, that patients who abuse growth hormone, exogenous growth hormone, they are more prone to have diabetes. If you ask me why, the answer is high amount of growth hormone will prevent the action of insulin. So that's that. Always try to remember physiological release of growth hormone will not cause diabetes. Only pathological release of growth hormone and exogenous abuse of growth hormone will cause diabetes. So always, so please write down over here, patho, meaning that this is pathological. So that's that. It's released in pulses in response to growth hormone releasing hormone. Once again, one more question. If hypothalamus stimulates the anti-pituitary in a pulsatile fashion, will we have increased growth hormone or decreased growth hormone? Fast answer, please. The answer is, if hypothalamus stimulates in a pulsatile fashion, then we can have increase. If I were to ask you that what would happen if the hypothalamus continuously stimulated the anti-pituitary hormone to release the growth hormone, what would be your answer? Increased growth hormone or decreased growth hormone? The answer is a decreased growth hormone. Okay, so that's that. Okay, very good. It's very similar to a condition. For example, let's say that you have a friend and you want something from that friend, right? And you ask that friend to give it to you. Let's say you ask for, let's say you ask for a book. Okay, you ask for a book, and let's say you ask for the book on Sunday. That your friend forgets to give you the book on Sunday. You ask for the book again on Tuesday, and he forgets on Tuesday. You ask your friend for the book again on Thursday. Then the possibility of your friend giving the book to you on Thursday is very high. But if you ask your friend about the book multiple times on Sunday, is there a possibility that you can irritate your friend? Yes or no, your friend can get irritated. Then why is he asking me about a book so many times in a single day? The answer is yes. So is there a possibility your friend will stop talking to you and you will not receive the book? The answer is yes. Yes or no? The answer is yes. Okay, so it's very similar to the hypothalamus and the pituitary. If the hypothalamus stimulates the pituitary in a pulsatile fashion, they will increase the secretion of the hormone. If they continuously stimulate the pituitary hormone, the pituitary gland will get irritated and they will stop producing the hormone. As simple as that. Okay, so let's move on to the next one. Growth hormone secretion increases during exercise, sleep, puberty, hypoglycemia. So that's that. So that's basically what I'm trying to say over here. Next one is growth hormone secretion will decrease by glucose and somatostatin. So please try to underline these conditions because these are stimulants that will be tested in your step 1 exam. So I'm just going to put a star over here. Excessive secretion of growth hormone by the pituitary adenoma may cause acromegaly. We know this, and the treatment is somatostatin analog or surgery. Okay, surgery or somatostatin analog. Please underline this. Okay. What is the name of the surgery that we would perform to get rid of the growth hormone releasing tumor? The surgery is called, it's called transsphenoidal resection of growth hormone producing tumor. So transsphenoidal resection, you know, like how we have the sphenoid bone, yes or no? Are we aware of the sphenoid bone in our cranium? Yes or no? Are we aware of the sphenoid bone? Sphenoid. Have we heard of the butterfly bone in the cranium called sphenoid? Sphenoid. Yes or no? Anyone? Okay, yes. So in order for us to resect the growth hormone producing tumor, the approach to the tumor has to be through the sphenoid bone. That's why the name is transsphenoidal resection, or TSR. So that's it. So that's what we will do. This is an extra piece of information for your clinical knowledge. This will not be testing your step 1 exam. You can try to write this down for your future reference. Now, let's move on to the next hormone, ADH, antidiuretic. We have already talked about this. Antidiuretic is also called vasopressin, meaning that antidiuretic hormone will work on 2 places. Number 1 is they will work in the kidneys. Another one is that they will work in the blood vessels. So that's it. In the blood vessels, I'm just gonna do this, artery and vein, so that you guys can remember this very quickly. Now, in the kidneys, in the distal convoluted tubule and the collecting ducts, the ADH will bind with V1 or V2. Fast answer, please. V1 or V2 receptors. The answer is very good. Okay, they will work via the V2 receptors. In the blood vessels, they will bind to the V1 receptors. Please do not forget this. Okay, please do not forget this. Okay? So they will regulate blood pressure by binding to the V1 receptors. What does this mean? This basically means that when we have low blood pressure, will there be excessive secretion of vasopressin or decreased secretion of vasopressin? The answer is, if the blood pressure is low, vasopressin secretion will be high. The answer is because they will go and bind to the V1 receptors and they will cause what? They will cause vasoconstriction. Okay, if we have vasoconstriction, how are we increasing our blood pressure? Let's say that this is the heart, yes or no? This is the left side, right side. If there's vasoconstriction, then what would happen to the pressure over here, high or low, afterload, left ventricular afterload, will it increase or decrease? The answer is the afterload of the left ventricle. If there is vasoconstriction, they will increase or decrease. Fast answer, very good. They will increase. If it increases, then will the left ventricle increase its force of contraction? Yes or no, to push the blood out? The left ventricle would increase its force of contraction to push the blood out. As a result, you can have increase of what? Systemic blood pressure. Very simple. So that's that. So vasopressin works this way. Next one is V2 receptor. We talked about this, that vasopressin or ADH, they go to the distal convoluted tubule, the collecting duct, and they stimulate the production of some channels, which we call aquaporin channels. These channels, they will increase the water permeability and increase the absorption of water. So that's it. Regulation, very easy. There are 2 things that will regulate this. Number 1 is plasma osmolarity. Please underline this. And hypovolemia. Very, very simple. Very simple. Please underline this. These are questions. Next one. I need to talk about a disease where we have low level of ADH secretion. This is called diabetes insipidus. Yes or no? Diabetes insipidus, where ADH secretion is low. If ADH secretion is low, will we have concentrated urine or dilute urine? Fast answers, please. Dilute urine, very good, meaning that we will have polyuria. Yes or no? Will we have polyuria? We will have to go to the washroom and pee more than usual. The answer is yes. Okay, meaning that if ADH is not there, will there be increased water absorption or decreased water absorption from the distal and the connecting tubules of the kidney? That's answer, please. Decrease. If there is decreased water absorption, will there be more water in the bladder? Yes or no? Yes, the answer is yes. As a result, if there's more water in the bladder, this will stretch the walls of the bladder, the drusa muscle, and by parasympathetic innervation, we will have more urination or micturition. So that's basically what this is now. Diabetes insipidus is basically 2 types. We have central and nephrogenic. Central means that hypothalamus is not producing enough vasopressin, meaning that there's something wrong with the hypothalamus. And nephrogenic means that there's something wrong with the V2 receptor, meaning that the production of ADH is normal, but ADH cannot go and bind to the V2 receptor. When it cannot bind to the V2 receptor, will we have increased aquaporin or decreased aquaporin? That's the answer, please. We will have Increase or decrease aquaporins? The answer is we will have decreased aquaporins. Very good. If there's decreased aquaporins, then water absorption will also decrease. As a result, we will have, once again, polyuria. But there is a difference. The difference is in ADH, if I have to talk about this, in central diabetes insipidus and nephrogenic diabetes insipidus, ADH levels, will it be high in central diabetes insipidus or will it be low in central diabetes insipidus? The answer is it will be low. Very good. In nephrogenic diabetes insipidus, due to homeostasis and negative feedback and all of those conditions, will it be high or will it be low? The answer is it could be normal or high. Very good. Okay. Usually it's high. Usually it's high. So that's it. Okay. So that's basically what this is. What is nephrogenic diabetes insipidus? I have already talked about this. This is a mutation or disruption or defective V2 receptor. So that's that. Another one is, I want to talk about this. If there is a patient with central diabetes insipidus, do they have decreased production of ADH? Yes or no? The answer is yes. If they have central diabetes insipidus, the answer is they have decreased production of ADH. Does that mean that you can supply ADH from the outside in the form of pharmacotherapy? The answer is yes. Okay. And will it work? The answer is yes. This pharmacotherapy is called desmopressin or ADH analog. This is what we provide for patients. But do we provide desmopressin for patients of nephrogenic diabetes insipidus? Yes or no? The answer is no. Why? Because there is no point in prescribing patients with desmopressin with nephrogenic diabetes insipidus because their V2 receptors are non-functional, they're not going to work. So there's absolutely no point in doing that. So that's it. Rather, what they will do is if you have a patient of nephrogenic diabetes insipidus and you give them ADH, they can have excessive amount of vasoconstriction and patients can have secondary heart failure. So that's that. Okay? So we have to be very careful when we prescribe ADH because we have to first confirm the diagnosis of central or peripheral or nephrogenic. So that's it. So that this is a questioning step 1 exam and also a clinical question. So please be careful of the type of answers you choose for your exam. That's that. Let's move on to the next one. Let's move on to prolactin. What is prolactin? What is the source? Once again, prolactin is secreted by the anterior pituitary hormone. It's structurally, what is the treatment of nephrogenic diabetes insipidus? It's a very good question. The treatment of nephrogenic diabetes insipidus is that we would like to give them thiazide diuretics. How does thiazide diuretics work for nephrogenic diabetes insipidus? We will talk about this in details in the renal system. Okay, are we clear? Yes or no? Are we good? Good. It's a very good question. Thank you so much for your question. Are you guys? Have you guys heard the answer? What is the treatment for nephrogenic diabetes insipidus? For step 1 from first aid, the answer is thiazide diuretics. Okay, thiazide diuretics. Now let's move on to the next one. Prolactin. Source of prolactin is anterior pituitary. Okay, what is the function of prolactin? The function of prolactin is that they will stimulate milk production in the breast. We are already aware of this. And prolactin will decrease ovulation in females and sperm production in males. As a result, they will decrease libido and they will cause infertility. Please try to remember this. Okay, so that's that. Prolactin regulation. Prolactin secretion is from the anterior pituitary. It is tonically inhibited by dopamine. As I have said before, high amount of dopamine. High dopamine will decrease prolactin. That's why we try to prescribe dopamine agonists for patients of small prolactinoma. So that's that. Prolactin in turn will inhibit its own secretion by increasing dopamine synthesis and secretion from the hypothalamus. So basically what prolactin does is prolactin, this is actually a very fun thing to understand over here, that prolactin, if it's high, prolactin is smart enough to decrease its own secretion. How? Do they directly go and inhibit the hypothalamus? Yes or no? Do they directly go and inhibit the hypothalamus, prolactin? The answer is no. Okay, they do not directly go and inhibit the hypothalamus. What they do is prolactin itself will increase the secretion of dopamine, and dopamine can then go and inhibit the secretion of prolactin. Are we clear about this? Yes or no? Everyone? Okay, once again, all the hormones in our body will have a negative feedback directly on the hypothalamus and pituitary, except which one? Except prolactin. Are we clear? Except prolactin. How? Prolactin will indirectly go and inhibit its own secretion by increasing the secretion of dopamine. Very simple. So that's it. Next one is thyrotropin releasing hormone. Sir, how does prolactin inhibit GnRH? Good question. Prolactin inhibits GnRH by, so the thing is, when prolactin is secreted, prolactin, what it does is, when they are secreted, they directly inhibit all the other secretions. For example, high amount of prolactin will decrease the secretion of thyrotropes. High amount of prolactin secretion will inhibit the secretion of GnRH releasing cells, and also POMC, pro-pyomelanocortin. So basically, the way that you can remember this is that the prolactin hormone is a selfish hormone. Yes or no? They are very selfish, meaning that they would only like to be secreted. They would not like to secrete any other hormones. Are we clear? Yes or no? Okay, so prolactin hormone is the selfish hormone. So that's it. Next one is TRH. TRH is thyrotropin releasing hormone that will increase the secretion of prolactin. We have already talked about this. Once again, hypothyroid patients, will they have high, normal, or low prolactin level? Fast answers, please. Hypothyroid patients will have high, normal, or low. Very good. They will have high or normal amount of prolactin. So that's it. Dopamine will inhibit the secretion of prolactin. I said this at least multiple times. They're used in the treatment of prolactinoma, depending if they are a small prolactinoma. So that's that. Large prolactinomas need to be removed. Dopamine antagonists can increase prolactin level because they decrease dopamine, and sometimes estrogen can also stimulate prolactin secretion, but it's exceptionally rare that estrogen will do this. I'm not going to use my red cursor for this one. Okay, this is not a question. So that's that. Okay. So that's basically what it is. Let's look at the picture over here very quickly so that we understand. First and foremost, prolactin secretion, sight and cry of the baby. What does this mean? When a baby cries, in majority of the time, does that mean that the baby is hungry? Yes or no? A very small baby, 0 to 6 months. Yes, if it's a baby of 0 to 6 months, if the baby, he or she is crying, that basically means that the baby is hungry. And when the mother sees or hears the cry of the baby, immediately what happens is that, let me tell you this, I think very interesting. This is a second. Look what happens. So what happens is when we have a small baby of 0 to 6 months and the baby is basically crying, what happens is over here, let me draw. Okay. This is your face of the mom. Okay. Excuse my drawing skills. Apologize for this. Long hair to sort of make you understand that it's a female I'm talking about. These are the ears of the mom, and these are the eyes of the mom, right? So the mom sees or the mom hears the cry of the baby. Immediately what happens is when the mom sees the cry of the baby, the optic pathway, they go from the optic nerve, optic tract, optic chiasm, all the way where? All the way to the optical cortex or the visual cortex, right? Or if the mom hears the cry of the baby, all the way this goes to the auditory center in the parietal regions, in the parieto-temporal regions, they go to the auditory cortex. From over here, with the help of white fibers or with the help of fasciculi, where will they go? They will go to the higher cortical centers, meaning that they will go to the frontal cortex. The frontal cortex, immediately what it does is, whenever the mother hears or sees the cries of the baby, the frontal cortex will stimulate what? The hypothalamus. That the baby needs food, the baby needs breast milk. The hypothalamus will immediately stimulate the pituitary. The pituitary will start producing prolactin and oxytocin. Now, prolactin, they will directly go to the mammary glands, and they will increase the production of the breast milk. And when the baby suckles and the baby is brought close to the mammary glands, the baby will suckle, and the suckling will initiate a suckling reflex where oxytocin will come out, and oxytocin will cause contractions of the myoepithelial cells. And this contraction of the myoepithelial cells will secrete the breast milk that was produced under the influence of prolactin. Very simple. So that's it. So let's see this over here in one more time. That over here you have the higher cortical center. They will stimulate the hypothalamus. How? By decreasing dopamine level, because once you decrease dopamine, prolactin levels will increase. And this increases the prolactin level, and the prolactin directly goes to the mammary glands, resulting in the production of breast milk. So that's that. Are we clear? Yes or no? The physiological secretion of prolactin. Yes. Have we understood this from this diagram? The mother sees, the mother hears. This goes to the visual cortex, auditory cortex. From there, it goes to the frontal cortex. From there, it goes to the hypothalamus, pituitary, and from the pituitary, you have prolactin. It goes to the mammary glands, resulting in the secretion, and meaning the production of breast milk. As simple as that. Okay, so that's that. Now, there are some other conditions. For example, reduced prolactin elimination can sometimes increase in prolactin. This is not high yield in the step 1 exam. Renal failure is not always associated with hyperprolactinemia, so you do not have to remember this. There are some medications that will decrease your prolactin levels, as we have already talked about. For example, antipsychotics, they will increase your prolactin directly, causing galactorrhea. Another one is prolactin. If it's high in amount, they will prevent menstruation and they will prevent fertility, they will decrease libido. So that's that. That's another thing. So this is all you guys, this is all you need to know from this page over here. Is everyone clear? Yes or no? Of prolactin, about prolactin? Is everyone clear about prolactin? Yes or no? Can I get some answers in the chat box? Is everyone clear about prolactin or not? Okay. Quick question. If a mother hears or sees the cry of the baby, which hormone will get secreted immediately? Fast answers, please. Prolactin. There's a question in the chat box. Let's see the question. The question is, what's the question? The question is, I'm sorry, this is confused with dopamine and TSH. Could you please repeat? Yes, I can repeat dopamine and TSH, but let me finish the lecture. After the lecture, I'll repeat it one more time. But for now, please bear with me. Now let's move on to the next question. The next question is, high amount of prolactin secretion will increase GnRH or will it decrease GnRH? The answer is decrease GnRH. In order for prolactin to be secreted, do we have to increase dopamine or decrease dopamine? Decrease dopamine. Very good. Antipsychotics, will they increase prolactin or decrease prolactin? Increase prolactin. Very good. If we want to treat prolactinomas, do we give more dopamine or less dopamine? Very simple. Very good. More dopamine. Okay. Wonderful. Thank you so much. Now let's move on to the next page over here. Let's see how much we have. Let's move on to the next page, thyroid hormones. Are you guys still with me? Yes or no? Are you guys tired? Are you guys understanding the lecture? Just want to make sure if you guys are understanding. Can I get a yes in the chat box? Yes or no? Yes, very good. Okay. Yeah. Is the lecture making the first aid easy to understand? Yes or no? Yes. Okay. Thank you so much for your feedback. Your feedbacks are very important for me, because if you guys are having trouble understanding the lecture over here, then I would like to reevaluate and restructure the lectures accordingly so that you guys can meet your needs. So that's so as long as you guys are understanding, let me continue to this page over here. Thyroid hormone. Is everyone ready for thyroid hormone? One of the most important hormones in our body. Yes. Is everyone ready? Okay, good. Let's begin with thyroid hormones. Now, thyroid hormone is produced by the thyroid follicular cells. So thyroid, it produces the hormone in the form of T3 and in the form of T4. Now, before I do this, let me talk about the production of thyroid hormone in a blank page. Very quickly, I'm going to explain this diagram and then I'll come back. So when we talk about the thyroid hormone, is this a life-saving hormone? Yes or no? Do we need thyroid hormone for our survival? Yes or no? Do we need thyroid hormone for our survival, or can we survive without thyroid hormone? Last answer, please. Can we survive without thyroid hormone? Yes or no? No. Okay. So we cannot survive without thyroid hormone. Can anyone tell me why? Okay, let me just give you the answer over here very quickly. Thyroid hormone is very, very important for us, for our survival, because thyroid hormone maintains our basal metabolic rate, BMR. How? How does thyroid hormone maintain our basal metabolic rate? The way that thyroid hormone maintains our basal metabolic rate is that thyroid hormone has synthetic functions. What do we mean by synthetic functions? Meaning that they are responsible for the synthesis of certain types of proteins. Okay, very simple. What type of proteins do they synthesize? The answer is very simple. All the sodium, potassium channels in our body are synthesized by the thyroid hormones. Are we clear? Yes or no? Can we survive without sodium, potassium channels? The answer is no. Okay. We cannot survive without sodium potassium channels, and the sodium potassium channels in our body are basically produced under the influence of thyroid hormone. So that's that. Now let's move on to how thyroid hormone is produced. First and foremost, we have the thyroid follicular cells, right? We have thyroid follicular cells, and we have the epithelial cell, and then we have the thyroid lumen. Okay, we have the lumen of the thyroid. What happens over here is, first and foremost, from the blood, this is a portion of the blood. What happens is we have a channel over here, which we call as a sodium iodide symporter. Sodium iodide symporter, what it does is that this sodium channel works in the same direction as the iodine, meaning that the sodium comes in and it brings the iodine along with it. Now, when the iodine comes, what happens is that basically the iodine will directly go through the follicular cells and it will be released into the lumen of the thyroid hormone. So that's number one process. Next thing is over here, we need a very high yield, amino acid. This amino acid that we need inside the thyroid follicular cell is the amino acid tyrosine. Tyrosine over here is converted to what? Thyroglobulin. Okay, are we clear about this? Yes or no? Tyrosine is converted to thyroglobulin. Then this thyroglobulin is released from the thyroid follicular cell into the lumen. And then we have what we call is the binding of the iodine and the thyroglobulin to produce some things that we call as monoiodotyrosine, diiodotyrosine. And when we have mono and diiodotyrosine, they sort of bind with each other, meaning that monoiodotyrosine is basically, it contains one, right? And di means two. So they can bind, that is MIT will bind with DIT to form what? T3. Or DIT will bind with DIT to form T4. That's how we get T3 and T4. Now, there are a couple of processes that I need to talk about. First and foremost, the iodine, when it goes to the thyroid follicular cells and it's released into the lumen, it is oxidized in the presence of oxygen. This process is called oxidation. This is one process over here. Another thing is when thyroglobulin binds with the oxidized iodine and forms MIT and DIT, this process is called organification. Have we heard of these terms before in our bachelor's of medicine and surgery? Physiology, yes or no? Yes, very simple, right? So that's it. Now, after we have organification, and what happens is after we have the production of these hormones, they will go back into the thyroid follicular cell And in the thyroid follicular cell, under the influence of protease proteolytic hormone, the MITs, DITs, everything, they will break down and they will release T3 and T4 into the blood. Very simple. That's that. Some of the iodine will deiodinize back and repeat the cycle, and that's it. So that's basically what I'm trying to say over here. This will make more sense when I go back to the picture we have. That's what I'm trying to say. Next one is over here. Let's come back to this page over here. Okay, so thyroid hormone. Did we understand the diagram over here? Yes or no? Do I repeat myself one more time? Do I repeat this diagram one more time, or should I move on? Last Francis, please. Good, clear? Okay, good. Let's move on. Now, thyroid produces T3, T4. We already said this, iodine-containing hormone. So let's say that you are in a region or you're in a country where you are not consuming enough iodine. Can you produce enough thyroid hormone? Yes or no? The answer is yes or no. Can you produce thyroid hormone? No. Now, is this a condition that you need to be worried about in a developed world? In a developed world, what is the reason for hypothyroidism? And in an underdeveloped world, what is the reason for hypothyroidism? In an underdeveloped world or a developing world where we have nutritional deficiencies, underdeveloped worlds, we have hypothyroidism because of iodine deficiencies. So if you have a patient who comes to you from Southeast Asia with long-term conditions of hypothyroidism, do you think about iodine deficiency? Yes or no? The answer is yes. If there is a patient who comes to you in the Western world, such as in US, and he comes to you suddenly with hypothyroidism, will you think about iodine deficiency? The answer is no. You will think about, very good, AI. That is autoimmune disease. It could be Hashimoto's, it could be any other autoimmune disease, it could be thyroiditis, but that should be the first concern. So that's it. Now, let's move on to the source. The follicles of the thyroid are the source of the production of the thyroid hormone. The 5' deiodinase will convert T4 to T3. Can you guys tell me over here, which one is the more potent form, T3 or T4, for the function of thyroid hormone? T3 or T4, which one is more important? Very good, T3. So T4 needs to be converted to T3 in the peripheral tissues, and the enzyme that does this is called 5' deiodinase, as simple as that. The peripheral conversion is inhibited. Now, this is a question in your step 1 exam. Please underline this. The peripheral conversion of T4 to T3 is inhibited by steroids, beta blockers, propyl thiouracil, or anti-thyroid drugs. And these 3 are exceptionally high. Please put your star marks from over here. You will be tested on this in step 1, step 2 CK, step 3, and all of those other tests time and time again. Next one. RT3 is a metabolically inactive byproduct of the conversion of T4, and it is non-functional. Its production is increased by growth hormone and glucocorticoid. This is not important. Functions of thyroid peroxidase is oxidation, which I talked about. That is the release of the iodine from the thyroid follicular cells into the lumen. Next, the function of thyroid peroxidase is the function of organification. That is the binding of thyroglobulin to the iodine over here. And also for coupling processes, that is for the coupling of monoiodotyrosine and diiodotyrosine. Now, anti-thyroid drugs, for example, propyl thiouracil and methimazole, these drugs, they will directly inhibit thyroid peroxidase. Always remember this. We'll talk about this in details in endocrine pharmacology. But for now, try to remember that anti-thyroid drug works by inhibiting thyroid peroxidase, as simple as that. Okay. Next one is the Wolff-Chaikoff effect. What is the Wolff-Chaikoff effect? The Wolff-Chaikoff effect is basically, it's a protective autoregulation. Sudden exposure to excessive iodine will prevent thyroid peroxidase. The same thing as I said before with the example of the friend and the book. For example, if you give iodine to the thyroid gland, okay, for example, let's say that this is your thyroid gland, right? And you give the thyroid gland iodine every day in a small amount. Will you have excessive thyroid hormone? Will you have increased thyroid hormone? My apologies, not excessive. Increased thyroid hormone production? The answer is yes. Okay. Yeah, but if you give excessive iodine all of a sudden to the thyroid gland, is there a possibility that the thyroid peroxidase can desaturate or become non-functional? The answer is yes or no. The answer is yes. So small amount of iodine is okay, but if you give a high amount of iodine to the thyroid gland all of a sudden, then this can desensitize or make your thyroid peroxidase non-functional. As a result, T3, T4 levels will decrease. This autoregulation is called Wolff-Chaikoff effect. Can anyone tell me how do we use this Wolff-Chaikoff effect in our clinical scenario? For example, if we have excessive thyroid hormone secreting adenoma or a thyroid adenoma, can we give high amount of radioactive iodine, yes or no, to the thyroid adenoma? Yes, yes. If we give high amount of radioactive iodine to the thyroid adenoma, will this prevent the secretion of thyroid hormone? The answer is yes or no. Yes, they will prevent the secretion of the thyroid hormone. As simple as that. Now, is anyone interested in knowing a very high yield step to CK question regarding this one? Yes or no, or should I keep this for later? You guys, okay, so let me just tell you over here very quickly. There's a very high yield step to CK question regarding this one. That is, if you give a patient of hyperthyroidism, all of a sudden, if you give them a high amount of radioactive iodine, what will happen? Will the patient become hypothyroid, or will the patient become hyperthyroid? Will the patient become hypothyroid immediately? Yes or no? The answer is yes or no. If there is a thyroid containing adenoma, and if you give them radioactive iodine all of a sudden, very good, Dr. Justine, the patient will suddenly become hypothyroid. So in order to prevent the hypothyroid effect of radioactive iodine after the treatment of a thyroid releasing adenoma, do you have to prescribe levothyroxine to the patient, yes or no, to prevent hypothyroid crisis? The answer is yes. Okay, so that's that. What do I want you guys to take from this question? I need you guys to take from this question is that radioactive iodine is exceptionally high yield, and it's very potent, meaning that a little amount of radioactive iodine, or I mean excessive amount of radioactive iodine used for the treatment of hypothyroid can suddenly cause hypothyroidism in your patients, as simple as that. Okay, so that's it. While I'm over here in this blank page, let me just talk about the functions of let me just talk about the functions of thyroid hormone very quickly. The physiological functions of the thyroid hormone. The physiological functions of the thyroid hormone, number one, BMR, meaning that it increases your BMR. How? By increasing the sodium potassium channels. If there's increased activity of the sodium potassium channels, will we have excessive amount of heat production? Yes or no? Will we have excessive amount of heat production? Yes or no? The answer is yes. Is that why hyperthyroid patients, they have heat intolerance? Yes or no? They cannot stand heat. The answer is yes. Okay. Very good. Next one is next one is they're used. Thyroid hormone is responsible for brain maturation. If there's a baby who has thyroid agenesis or dysgenesis, or the mother had iodine deficiency, do these babies come out as cretin babies? Cretinism, yes or no? With mental retardation? The answer is yes. Okay. So if I ask you, do I need thyroid hormone for brain maturation? The answer is yes. Okay. That's that. Next one, thyroid hormone. Thyroid hormone, it increases your blood sugar. Okay, it's a hyperglycemic hormone. They will increase your blood sugar. Next one, thyroid hormone, excessive amount of thyroid hormone. Hyperthyroid patients, are they lean or are they obese, or do they accumulate more fat? Fast answers, please. Hyperthyroid, they are lean, meaning that they will break down lipids, meaning that thyroid hormone will break down lipids, meaning that it's a lipolytic hormone, as simple as that. Next one, high yield one, that is thyroid hormone, they have beta adrenergic effect, meaning that high amount of thyroid hormone Will it increase cardiac output, heart rate, stroke volume, contractility? Yes or no? The answer is yes. Very simple. Okay. Does that mean patients of hypothyroid patients, they will be bradycardic? Yes. Will they have decreased or delayed reflexes? The answer is yes. Okay. Will they have hypothyroid patients? Will they have cold intolerance? Yes. Hypothyroid patients in young babies, will they have problem with brain maturation? The answer is yes. Will they be hyperglycemic or hypoglycemic? The answer is hypothyroid patients will be hyper or hypo. The answer is hyper. They will be hyperglycemic. So that's that. Next one is they will have increased amount of lipid accumulation, meaning that they will be more on the obese side. That's as simple as that. Okay, so that's what I'm trying to say over here. Okay, are we clear? Yes or no? Hypoglycemic, my apologies. Yes. Okay, are we clear? Okay, good. How does TH increase cholesterol level? Thyroid hormone does not increase cholesterol level. Thyroid depletion increases cholesterol level. Are we clear? Hypothyroid patients have increased cholesterol. Hyperthyroid patients do not have increased cholesterol. Okay, are we clear? Let's move on to the next one. Is everyone ready for this portion of the page? Everyone, are we ready for this portion of the page a little bit? Okay, so these are the functions of the thyroid hormone. They are not very heavily tested in your exam, but just try to remember some. I'm just going to put underline the third one. This is high yield. This is high yield. And this is high yield blood sugar. Try to remember these three because there is a possibility I may have seen questions regarding these ones in the past, but they're not very heavily tested. They're very mildly tested. So underline this for your own benefit. Next one is regulation. Regulation is TRH. We know this, hypothalamus, pituitary, thyroid. Very simple. TRH will stimulate TSH. TSH will stimulate your T3, T4. Now, hypothyroid patients, will they have decreased T3, T4 and increased TSH? Yes or no? The lab finding should be very similar to something like this. Yes or no? Out of T3, T4 and TSH, which one is more sensitive to detect hypothyroidism? T3, T4 or TSH? The answer is very simple. The answer is TSH. Okay, good job. Next one is negative feedback. Negative feedback is primarily by T3, T4. They have a feedback on the anterior pituitary or the hypothalamus. And when we have feedbacks as such, they will decrease the sensitivity to TRH and they will decrease TRH secretion. As a result, TSH secretion will also decrease and patients will have low amount of thyroid hormone. Now, I want to talk about one more thing before I stop the lecture for today. Over here, very quickly, is, let's see, 1 second. Okay. What I want to talk about is this. Thyroid hormone, do they roam around in the blood by themselves, or do they roam around with the help of thyroid binding globulin? Fast answers, please. Do they roam around by themselves, or do they roam around with the help of carrier proteins? They roam around with the help of carrier proteins, very good, like globulin. So answer me this. If a thyroid hormone is bound to thyroid binding globulin, is the hormone functional or non-functional? Fast answers, please. This is non-functional, inactive, very good, non-functional, NF. So if there are certain drugs and certain conditions where your thyroid binding globulin increases, can patients have subclinical hypothyroidism? Yes or no? Because T3, T4 will become inactive. The answer is yes, very good. Now, the next question is, what are the drugs and what is the condition where thyroid binding globulin will increase? Number one, drug, oral contraceptive pill, OCP, ethinyl estradiol, and progesterone. These two things will increase your thyroid binding globulin Patients who are continuously having OCP are more prone to develop hypothyroidism, number one. Number two, which condition will increase your thyroid binding globulin? The next condition is pregnancy. During pregnancy, thyroid binding globulin will increase. If it increases, they will bind more and they can cause subclinical hypothyroidism. Are we clear? Yes or no? Yes or no? Yes or no? Are we clear? Okay. Next one. Next question. Next question. If you have decreased thyroid binding globulin, do you have excessive functional T3, T4? Yes or no? The answer is yes. Now, what are the conditions where thyroid binding globulin will decrease? Number one, drug. Which drug? Corticosteroids or steroids? Patients who use steroids, especially let's say anabolic steroids, they are more prone to develop hyperthyroidism. Number two, patients who have nephrotic syndrome, they can have excessive loss of protein through their urine, right? So that's that. So that's basically, that's high yield for first menopause, is not high yield for thyroid binding globulin, so I'm not going to say that. For step one, you need to remember steroids, nephrotic syndrome, OCPs, and pregnancy. OCP and pregnancy will increase your thyroid binding globulin, resulting in decreased T3, T4. Nephrotic syndrome and steroid use will decrease thyroid binding globulin, resulting in increased T3, T4. That's simple as that. Are we clear? Yes or no? Are we clear about this? Yes. Very good. So with that being said, we are going to conclude the first aid portion of our lecture over here. And we will directly move on to AMBOSS. Okay. Did everyone understand the first aid lecture for today? Yes or no? Did everyone understand the first aid lecture? Yes or no? Okay, good. So as I said at the beginning of our lecture over here, let me just pull this out very quickly. At the beginning of our lecture, this is what I said. What I said is that Dr. Hadi's step one lectures, the class timings are this. Resources is first aid step one, which we have used. Next thing that I want to talk about is UWorld question bank, which I will after the end of our lecture. The third thing is AMBOSS question bank, which we will be directly using every day during our lecture after the end to incorporate whether we have understood the question for today or not. Next one is the TOMA, which I'll talk about, and preview, which I'll also talk about. Let's move on to AMBOSS question bank. You guys do not need to buy this question bank by yourself because we have already purchased the question bank for you. And we will be solving questions from here. Now, if we solve questions from AMBOSS every day, does this give you the space to solve UWorld questions by yourself? Yes or no? That's yes, please. The answer is yes. Okay. If we were to solve UWorld questions in our class, could you assess your performance? Yes or no? The answer is no, you cannot assess your performance if you solve UWorld in the class. So previously, what we did was we used to solve UWorld offline questions, but for this batch of students, we will be directly solving questions from the online AMBOSS question bank, which we have purchased over here. And that's what we will do. So let me just change the status to not yet answered. So AMBOSS has 2,716 questions for step one online. Let me choose the system over here. The system that I want to choose today is the endocrine system. The discipline that I want to choose is, okay, no discipline. Everything is okay. Difficulty status is normal. Okay, so let's begin. What about UWorld? Exactly, UWorld is something which you guys will solve by yourself in your free time. we will not be solving UWorld in our class. We will be solving AMBOSS. The reason being is because, one more time, let me repeat myself. If we solve UWorld in the class, can you assess your performance in UWorld? Because this is something which you will solve with me, so you cannot assess your performance. We need UWorld. We need you guys to solve UWorld by yourselves, so that you guys can assess your performance and you guys can understand. Now, AMBOSS is something which we have provided for you, meaning that we bought AMBOSS for you. So do you need to buy AMBOSS? The answer is no. Why? Because we have already purchased AMBOSS for you. We will be solving AMBOSS questions in the class. In class. Are we clear? We will be solving AMBOSS in class. If we solve AMBOSS in class, does this give you enough space to solve UWorld at your own time? The answer is yes. Okay. Now, another question. Which one is more difficult? Which one is a more difficult question bank, UWorld or AMBOSS? Which one? The answer is, I'm sure you guys all know that. Which one is the most difficult question bank? Answer is, UWorld is not the correct answer. The correct answer is AMBOSS is the most difficult question bank. So if you solve AMBOSS, then you guys will have enough information to solve UWorld. Next question, which one is more relevant and which one is more similar to the actual step 1 exam, UWorld or AMBOSS? The answer is UWorld. Excessively and exceptionally high yield and exceptionally similar to the actual step 1 exam. Are we clear? Yes or no? About the AMBOSS and UWorld? Yes. Okay. First, so fast questions, fast answers. Which question bank will we be solving in our class, UWorld or AMBOSS? The answer is AMBOSS. Do you guys need to buy or purchase AMBOSS? Yes or no? The answer is no. You guys not need to purchase AMBOSS. Good. After solving AMBOSS, which question bank will we solve in our own time, in our house, by ourselves to assess our performance? The answer is UWorld. Are we clear? Okay, good. Perfect. Now let's begin with today. So we do not have a lot of time. Our time for today was at 11:30. So let me just extend. We won't do a lot of questions since it's the first class. So let me just stick to doing 10 questions for today. From the endocrine system, as you guys can see, endocrine system has only 153 questions in your AMBOSS Q bank. I'm not sure if we will be able to solve all the 153, but we will be doing a little bit of questions every day. So that's that. So with that being said, what I want to do is begin. Is everyone ready? Yes or no? Okay. Is everyone ready? Okay. Let's begin with AMBOSS question. Yeah. Okay. First question over here. Before you guys solve the question, I need you guys to have a pen and a paper ready by your side so that you guys can write the answer by yourself. After you guys have the pen and the paper ready, can I get a yes in the chat box, please? Yes. Okay, everyone's ready now. Okay, so this is how we will solve the questions. First, this is a typical step 1 question. Okay, a typical step 1 question. Now, first and foremost, USMLE step 1. Let me just talk about this 1 second. USMLE step 1 is an 8-hour exam in a single day, meaning that you have to finish the entire exam in a single day. It's an 8-hour time course. You will get 1 hour for break. 7 hours the entire course. Per hour, you need to solve 40 questions in one block. One block has 40 questions similar to this type. So if we have to solve one question, how much time do we have to solve one question? So on an average, we have 90 seconds for each question. Are we clear? We have 90 seconds for each question. So the challenge is basically how you utilize that 90 seconds to understand the question, what they're asking you from, and choose the right answer from A, B, C, D, and E. Now, how do we utilize the 90 seconds? What we're going to talk about right now is how to read a step one question. The first thing that we do is read the last line of the question very quickly before we even see. So for example, over here, what is the last line of the question asking you? Further evaluation of this patient is most likely to show increased serum concentration of which of the following hormones? Calcitonin, gastrin, metanephrine, thyroid stimulating hormone, or parathyroid hormone. So now we have seen the last line. We have seen the answers. So basically, the question is asking you something regarding a patient who is undergoing a pathological condition for which one of these following hormones are very high. So that's that. So now, since we know what the question is asking you, let's start the question from the beginning over here. A 40-year-old man, always try to understand who we are considering the patients, if it's a man or a woman, and what the age of the patient is. So you guys can underline this, like this one over here. So what we do is we do this 40-year-old man, underline, comes to the physician because of a chief complaint. The complaint is a 1-month history of a painless lump on his neck. Okay, so 40-year-old man, painless lump. 2 years ago, he underwent surgery for treatment-resistant hypertension, headache, palpitations. Okay, so he had a history of these conditions. Now the physical examination shows a firm swelling on the right side of the neck. Ultrasonogram shows a 2-centimeter nodule with irregular margins and microcalcification in the right thyroid lobe. So over here, what you need to take from this one is that these patients, this is a patient of multiple endocrine neoplasia. Okay, so we will talk about this in the future. Now, if you guys have your answers, can you please write down the answer A, B, C, D, or E in your own page? Okay, are you guys done? Yes or no? If you guys are done, then I'll move on to the next question. Okay, I'll move on to the next question. Okay, what is the next question? Let's see. Okay, done. Next question. Read the last line first. Administration of the drug is most likely to result in decreased activity of which of the following secretions of the normal adrenal gland. Now, this is something which we have already discussed, how to read the histology of the adrenal gland. As you can see from over here, we have A, B, C, D, and E. We have zona glomerulosa with the glomerular containing cells. We have fasciculata over here with the fasciculi. We have a reticular pattern of the organ reticularis. And we have A and E. So from over here, you need to choose which one is the following answer for this patient. 42-year-old man comes to the physician with a follow-up of the examination. He has hypertension. Subsequent blood pressure have ranged from 135 by 83 to 156 by 96. Now today, his blood pressure is 141 by 85. As you can see from over here, physical examination shows no abnormalities. Pharmacotherapy with lisinopril, which is an ACE inhibitor, is initiated. Administration of ACE inhibitor is most likely to result in decreased activity of which of the following secretions of the normal adrenal glands. So ACE inhibitors will prevent angiotensin II. If angiotensin II is not working, which one of the following portions of the glands will it be affected? Will it be the glomerulosa? Will it be the fasciculata? Will it be reticularis? I'm pretty sure you guys will understand which one the answer is. If you guys are done, can I get a done in the chat box, please? Fast answers in the done chat box. Move on to the next question. Done. Okay, very good. Next question. Which of the following is the most likely explanation of this patient's MRI findings over here? 36-year-old woman is brought to the emergency ER 20 minutes after she slipped on an ice and hit her head. She is conscious on arrival. She has not had her menses for the past 6 months and has a weight gain. Menses have previously occurred at regular day arrival. She has no history of illness and takes no medication. She is 160 centimeter and is obese. So on a physical examination, you see that she has a laceration in the occipital region. Beta HCG is high, MRI of the brain shows an enlargement of the pituitary gland. Which one of the following explains all of these conditions? Please read the question one more time, read the answer one more time. And after that, select your answer and write done in the chat box. I will not help you with this one. If you guys are done, please write done. Done. Okay, next question. 1 second. Next question. Read the last line. Which of the following, blah, blah, blah. Read the answers very quickly. I will not be helping you with this one. Read the answers very quickly. After you read the answers and the last line, you should have an idea of what the question is asking you. Now, please go back to the first portion. Look at your patient, male or female. Look at the age of the patient. Look at the chief complaint. Chief complaint is tall stature. Let's look at the family history. Now, let's look at the examination. Okay, bossing and protrusion of the mandible, hyperglycemia, everything shows that the patient has excessive growth hormone, so we know what we're talking about. If you guys are done, please write done. If you guys are done, can I get a done in the chat box, please? Done. Very good. Is everyone done? Yes or no? Is everyone done? Yes or no? Yes. Okay, let's move on to the next one. Okay, 7-year-old girl is brought to the physician by her mother for a well child examination. The mother reports that she has had her first menstrual period 1 week ago. A 7-year-old child, a 7-year-old female girl. She has no history of serious illness. Immunizations are up to date. Physical examination shows that she has a Tanner stage 3 breast development, meaning that she has telarchy. Telarchy means okay. Please refrain from unmuting yourselves. If you guys have questions, use the chat box. Okay. Without treatment, the patient is at greatest risk for which of the following as an adult. Okay. If you guys are done, can I get a done in the chat box, please? Done. Anyone else? Okay, Dr. Ita, Dr. Litala, Dr. Rahman, Dr. VK, Dr. Fire Tablet, everyone is done. Okay, so I'm going to move on to the next one. Let's move on to the next one. Further evaluation shows low renin activity. Which of the following is the most likely diagnosis? Look at the potassium level. Patient is hypokalemic. Look at the sodium level, the borderline hypernatremia. Should be something about aldosterone being high. I'm not sure. Let's look at the question pattern. 32-year-old woman comes to the physician because of 2-month history of fatigue, weakness, headache, palpitation. Pulse is 75, blood pressure is 152. Now, which one of this is the following answer? The renin is low, meaning that the renin-angiotensin-aldosterone system is not being activated by the renin itself, meaning that the gland is secreting excessive aldosterone by itself. So you guys should know the answer from over here. Okay. If you guys are done, then can I move on to the next one? Done. Okay, done. Okay. Now let's move on to the next question. The next question is this one over here. Which of the following sets of changes is most likely in this patient? So we have estrogen, progesterone, dopamine synthesis. As you can see, you have your table A, B, C, D, E, which shows increase or decrease of the following hormones. Let's look at the question scenario, the patient profile. The 35-year-old woman. She comes to you because of headaches, menses, and discharge from the nipples for the past 4 months. Okay, all of this are pointing you to an excessive secretion of a single hormone. Breast shows milk whitey discharge, also known as galactorrhea. Thyroid is normal. Morning cortisol is normal. Pregnancy is negative. MRI is shown. Now, which one of the following changes do you expect in this patient? Let's look at the imaging over here very quickly. This is the imaging. As you can see, there's something wrong with the patient's pituitary gland and the cella turcica. Okay. If you guys are done, can I move on to the next question? Yes or no? Done or not? Done. Very good. Let's move on. This should be a difficult question. Let's move. Let's read the question over here very quickly. Further evaluation is most likely to show which of the following. Now you have these answers over here: increase PCO2, increase pH, excessive water retention, serum glucose concentration is high, decreased total body potassium. Now, a previously healthy 14-year-old girl is brought to the ER by her mother because of abdominal pain, nausea, and vomiting for 6 hours. Now, over the past 6 weeks, she has also had increased frequency of micturition, has been drinking a lot of water. Okay, let's look at what's wrong with her. Deep labored breathing and dry mucous membrane. This is a scenario of, can anyone tell me the scenario of this one? Patient has dry mucus, very good, DKA, diabetic ketoacidosis. Okay, right. So the rest is on you. Let's see how you guys do this. Which one of this is the following answer? If you guys are done, can I please get a done on the chat box, please? So that I can move on to the next question. Are you guys done? Done. Anyone else? Okay. Done. Okay, good. Let's start with this one. Let's read the first line. The last line of the question. They're asking you which one of this is the following diagnosis. The diagnosis is TIA, apoplexy, Sheehan, migraine, seborrheic or the cluster headache. So a 39-year-old woman with a history of migraine is brought to the ER because of severe sudden onset throbbing headache and double vision. Okay, this does not sound very good. Now, sudden onset of severe headache, she says that she has been having frequent headaches and then has not had her period in several months. Blood pressure is somewhat low. Visual testing shows decreased visual acuity and loss of peripheral vision, very similar to the signs symptoms which we talked about today. Okay, if you guys are done, please let me know in the chat box which one of this is the correct answer. Done. Anyone else? Okay, let's move on to the last one. Which of the following is the most likely underlying cause of this patient's symptoms? So we have Graves' disease, exogenous levothyroxine, granulomatous thyroiditis, iodine exposure, or NDC. So we have a 75-year-old woman, patient profile. It's an old woman, brought to the physician by her daughter because of a 1-month history of fatigue and weight loss. The patient has fatigue and weight loss. It does not look very good. She has a history of hypertension, hyperlipidemia, and dementia. She lives with her daughter and requires assistance. Daughter has hypothyroidism. She does not remember the names of the medication, but says she takes them every day. Her pulse is tachycardic. Blood pressure is hypertensive. Physical examination shows warm skin and a tremor. Okay, so thyroid gland is not palpable. TSH level, the serum thyroid stimulating level is not undetectable. Histological examination shows follicular atrophy. Okay, now this is an interesting one. If you guys are done, please let me know. There are a couple of issues with this one. Patient has hyperthyroidism, but the PSH level is not detected, and thyroid gland itself is atrophic. So that must mean that there is something going on over here. If you guys are done, please write done in the chat box. Done? Okay, done. Anyone else? Done. Okay. Now, for your step one exam, how many questions out of 10 questions do you have to get right on a basis to make sure that you pass the exam? Does anyone know? Does anyone know how many questions should you get right out of 10? No, 192 is the total amount, but out of 10, what is the percentage that you should go for? Seven's a bit too much, I would say. 6 is minimum, or 5 is minimum. At least 5 out of 10 questions should be right out of 10 questions, all in all, in order for you to pass the exam. If you want to do good, then 7 or 8 questions should be right out of every 10 questions, more or less. Okay. So with that being said, I'm not trying to pressurize you guys, since this is the first time you guys are solving your Yosemite step one questions, but let's see how you guys did. First question. This question was about a painless lump on the neck, episodic headache, and palpitations. I said it was about multiple endocrine neoplasia. Let's see what the answer is. Should be A, very good, calcitonin, that is. Medullary thyroid carcinoma, and it's a MEN2. When we talk about MEN2 in the future, I'll talk about this over here. What is MEN2? Okay, so your multiple endocrine neoplasia is basically familial tumor syndrome, especially MEN2. Okay, especially MEN2. This happens due to a mutation in a gene called RET oncogene. Patients have 3 types of condition. They have MPH. MPH stands for medullary thyroid carcinoma. P stands for pheochromocytoma. H stands for hyperthyroidism. Hyperparathyroidism. That means hyperparathyroid. I don't know. So that's them. These are the 3 things. So this patient has a medullary thyroid carcinoma, and I knew this already because the patient has signs symptoms of pheochromocytoma. Hypertension, headaches, and palpitations, are they the reason of increased secretion of epinephrine, norepinephrine? Fast answers, please, yes or no. We do not have a lot of time. Epinephrine, norepinephrine, do they cause hypertension, episodic headaches, and palpitations? Yes or no? The answer is yes. So a patient who is a 40-year-old patient should not be suffering from hypertension, episodic headaches, and palpitation all of a sudden, and there should not be any swelling. So this shows that the patient has a carcinoma, and especially medullary thyroid carcinoma is a carcinoma of the parafollicular cells. And as we have discussed before, parafollicular cells are responsible for the secretion of what? Thyroglobulin or calcitonin? Which one? Fast answers, please. They're responsible for the secretion of calcitonin. So here you go. This should be your answer, calcitonin. Next question. Let's move on to this. We already knew what this was. We were looking for zona glomerulosa. Obviously, the zona glomerulosa, as I have said before, is the glomerular containing cells. So this is the globular cells over here. B is your answer. Okay. Are we clear? Yes or no? Should I move on to the next question? Okay, let's move on to the next question. A 36-year-old woman, after she slipped on an eye, she's considered, okay, BMI 36, show the bleeding laceration, enlargement of the pituitary gland. Okay, good. Which one of this is the following answer? Let's see over here very quickly. It's a functional hyperplasia, meaning that there is no direct pituitary tumor over here. It's not a prolactinoma, which a lot of people might have chosen, but it's the wrong answer, because over here, the patient has increased amount of HCG, which means that the patient is pregnant. So we should have known this before, that the patient is pregnant. That's why in pregnancy, you have increased amount of prolactin secretion, as we have studied today, that in pregnancy, prolactin increases so that there could be production of milk in the mammary glands. So as a result of the stimulus from the beta HCG, the prolactin hormone has a functional hyperplasia. So that's that. If you have chosen prolactinoma, then the answer is wrong. If you have chosen functional hyperplasia, then the answer is right. If you have chosen prolactinoma, please do not be disheartened, because as you can see, a lot of people chose this, and that's how you learn from your mistakes. That's that. Does recalls come in USMLE question? Let me answer this question after the end of the lecture. Okay, let me just move on to the next question over here very quickly. 14-year-old boy is brought to the physician for his tall stature. His father is this. He is at the 99th percentile for his age. X-ray of the left hand shows a bone age of 16 years. We all know what this condition is. This should be B, right? Because this is gigantism, excessive secretion of growth hormone, insulin, like growth factor. Yes or no? Are we clear about this one? Yes or no? This should be a very easy one. Okay. Okay, let me move forward to the next one over here. 7-year-old girl has premature puberty, right? Physical examination shows Tanner stage 3 breast development and pubic hair development. Without treatment, the patient is at greatest risk for which one? Let's see the answer. The answer is short stature. Why? Why? Because these patients, if you have premature puberty or premature release of hormone, the secondary ossification centers in your bone, do they close? Yes or no? Fast answer, please. The secondary ossification centers in your bones, they will close or they will stop at an earlier age, and patients will have short stature. Very simple. Okay. Next question. 32-year-old woman comes to the physician because of history, this and this. I already gave you a very important tip. The answer should be C, aldosteronoma, meaning that the renin is low, but aldosterone is high, meaning that renin-angiotensin aldosterone is not involved in the aldosterone secretion. So aldosteronoma. Okay. Are we clear about this? Yes or no? I think the answer is yes. Oops. Are we clear about this? Yes or no? Can we move on to the next one? Okay. Is this fun or not? Look, are you guys having fun understanding and reading the questions? Yes, these are pretty easy. Are they related to the topics which we studied today? Yes or no? The answer is yes. Okay. Let's move on to the next one. Next one is this patient over here with this ball and the cell of carsica showing that she has a pituitary tumor. Most probably it's a prolactinoma. Let's see what the answer is. The answer is D, okay? Because everything will be low. Since prolactin is increased, meaning that you have low amount of GnRH, estrogen and progesterone will decrease, and dopamine synthesis will increase. Why? Because dopamine will try to decrease the prolactin level. Because do you guys remember I told you excessive prolactin will increase dopamine secretion. They will indirectly inhibit its own secretion. So that's that. It's the only hormone that will indirectly inhibit its own secretion by increasing dopamine level. That's why dopamine will increase. So the answer is D. Okay. Very simple. Next one. This is DKA. The answer should be D. But as you can see over here, a lot of students, they chose this answer over here. This is actually wrong. The answer should be that in DKA, the serum concentration of glucose should be not more than 600 to 650. The answer should be that the total body potassium actually decreases. If you ask me why, then the reason why is because when we have excessive amount of blood glucose level and patients have diabetic ketoacidosis, patients have a lower pH and high amount of hydrogen. The high amount of hydrogen will switch and they will go inside the cell and potassium will come out of the cell. By the action of the hydrogen potassium, ATP is pumped. So that's why we have high amount of potassium out extracellularly, but the total body potassium is decreased. This is something that we will study in details in the future, but for now, if you have chosen B, then unfortunately it's the wrong answer. If you have chosen E, then congratulations, you have chosen the right answer. This is a difficult one. Next one is this one. Patients have decreased visual acuity and loss of peripheral vision. Which of the following is the most likely diagnosis? Let's see what the answer is. Very simple. It's an apoplexy, meaning that it's a pituitary hemorrhage, pituitary apoplexy. Patient has double vision, throbbing headache, That's that. Are we clear about this question? Yes or no? Are we clear about this question? Yeah, yes or no? Okay. Very good. Next and the last question, this one. Okay. Let's see. The last question, which one do you think the answer is? Which one is the correct answer? Okay. B. Because we have one student, we have one physician, Dr. Tasmin, who said B. We have another physician, Dr. Dahavia, who said B. Let's see what the correct answer is. I think it's B. Very good. Very, very good, Dr. Tasmin. This is exogenous levothyroxine use. Now, this is something that you have to understand, that all patients who have Alzheimer's dementia, they are not aware of the type of medications which they can be taking. So they can abuse different types of medications. Number one. Number two is, in US, we have a high prevalence of elderly abuse, meaning that in US, elders are abused more because when they stay with their family, if the family is not taking care of them, or if the family is trying to abuse the elders, what they will do is that, especially if the elderly has Alzheimer's dementia, they will make sure that the elderly patients, they have certain clinical condition for which they could be admitted to the hospital, so that they do not need to stay with the family members in their own house. So this is a form of elderly abuse. But in this case over here, this patient has dementia. That's why she abused the medication by mistake. So that's why the answer is levothyroxine use, because when we use thyroxine from outside, they will decrease TSH level and your thyroid glands will become atrophic. As simple as that. Are we clear? Yes or no? So that's all for today. How many of you guys had 4 right answers out of 10 for today's exam? If you guys have 4 out of 10, then you have passed the exam. 5 out of 10, very good. 5 out of 10, very good. Okay, 5 out of 10. 8 out of 10, exceptionally good. Okay, very good. 5 out of 10 is very good. 4 out of 10 is the passing mark. We have another student with 7 out of 10, very good. Okay, so good job, guys, for your first class today, for the first exam. You guys did very well, exceptionally. Okay, now, let me answer a couple of questions over here by Dr. Rahman. If you want to unmute yourself and ask me the question directly, you are more than welcome to do so. What about recalls? What do you mean by that? Can you elaborate a little bit more, please?
Recalls are the questions which came in the previous exams.
Oh, your question is, will the exam?
Yes, past questions.
Yes, your question is, will the questions in the previous exams get repeated in the next exam? Is that your question?
Yes, sir.
Okay, so the answer for that is yes. And the way that you will know what type of questions are being asked in the previous questions is if you do, or if you practice UWorld question bank. So the thing is, UWorld question bank has around 4,000 step 1 questions. Each and every month, they keep on adding new questions. These new questions are the questions that are asked in the actual exam. So if you are up to date with UWorld solving methods and UWorld questions, then there should not be any issue. So to answer your question, the answer is yes, meaning that questions are repeated. Questions that are asked in the past exams will get asked again in the next exam. Okay, next question. Who has the next question? Does anyone have any other question? You are very welcome. Okay. Does anyone have any other question regarding our lecture? Okay. If you guys have any question regarding today's lecture, now is the time to ask. If you guys have questions about our resource, timing, duration, everything. Dopamine, TSH, yes, Dr. Suhila. Okay, so now what question do you have regarding dopamine and TSH? Are you asking whether dopamine will increase TSH or decrease TSH? Is that the question? Yes, dopamine. Dopamine will increase TSH. Dopamine will help with hypothyroidism. If patients are taking dopamine, then they will have PSH that will increase, and PSH will increase in a normal amount, not in an abnormal amount. The mechanism is very simple. Dopamine will directly go and it will affect the TRH of the hypothalamus, resulting in the release of PSH in the pituitary and increase in T2T for a simple. Are we clear? Yes or no? Okay. Are we clear? Very good. Okay, you're very welcome. Next one. Next question. Do we get study plan every week? Okay, Dr. Aditya. Are you Dr. Aditya who was with us in the first and the second batch? Yes or no? If you are, can I get a yes in the chat box? Yes. Okay. Thank you so much for joining our lecture. Once again, we highly appreciate your presence. And to answer your question is yes, do we get study plans? Yes, we get study plans every week. Okay. Next question is a very good question. The question is, sir, how much do we have to pay for classes? Very good question. Does anyone else have this question in their mind? How much do we have to pay for the classes? Who else is thinking about this payment? Good, very good. Okay. Who else? Who else is thinking about payment? So to answer your question, thank you so much for asking the question. The question is how much we have to pay for the classes. How? Me too. Okay, good. So for now, we are conducting free classes because we want to, we always conduct free classes for the first couple of days because we want you guys to decide if we are the right fit for your step one preparation or not. Is that fair? Because I do not want to charge you guys with any type of payment as of right now, because I want you guys to try us out. I want you guys to see if there is any sort of synchronization with your study method and our study techniques. If it is, and if you want to continue in the future, then our then our payment method is very simple. I do not want to talk about the payment as of right now. Let's finish the free classes first, and then after we finish the free classes, I'll talk about how much we have to pay, and that's that. Is that okay? Yes or no? Okay. Now, do we have any other student from the first batches? We have Dr. Aditya. Can we get a yes from Dr. Aditya in the chat box so that I know that you're there? Dr. Aditya, okay, yes. Who else is here? Dr. Noor Mohammed, Dr. Nicole, Dr. Midula, Dr. Rafiq, all the previous students. Dr. Suhila is also there. Dr. Dali is also there. Dr. Nazar is also there. Thank you so much for joining the lecture once again. Very good to see you guys one more time in our lecture. Now, if I have to ask regarding the payments, Dr. Ibrahim is also there. Thank you so much. If I have to ask regarding the payments, are the charges fair that we charge our students? Yes or no? Do we charge fair charges? Okay, fair charges. Okay, so nothing to be worried about. Very, very reasonable. As you can see from our previous students who has been with us for a couple of months now. So that's that. Okay, so don't worry about the charges. For now, please enjoy and participate and appreciate the free classes which we're giving out. And we'll talk about the payments next week. Any other question? No more question? Okay, good. So, okay, so now let me ask you guys a question. Do you guys understand the lecture for today? Yes or no? Fast answers, please. Do you guys understand the lecture for today? Yes. Okay. Do you guys enjoy the lecture for today? Yes or no? Okay, good. Very good. As long as you understood the lecture and you enjoyed the lecture, that's all we need. Now, if you guys have understood and enjoyed the lecture, if you guys have friends who are willing to join free classes and who needs help with their step one, can we ask you guys to invite them to our free classes? Yes or no? Okay. Now, the reason being is because a lot of step one tutors, they overcharge a lot of students. But for now, we are conducting free classes, and a lot of tutors do not conduct free classes. So as long as the classes are free, please try to share the link of the class as much as possible. Please try to ask your friends to come and join the class as much as possible so that everyone can benefit from the lectures. After you receive the lecture or whatever you learn from the lecture, if you feel the need to share with your friends, please do so that everyone can benefit. Link for the video will be provided in your emails, respectively. Please also keep an eye on our page and on our YouTube channel for more of these videos. And free lectures will be provided to everyone. Okay, so that's that. So with that being said, it's 12 p.m. as of right now. I want to conclude the first class of the third batch. If that's all, then can I take my leave? And I'll see you guys tomorrow once again at 8:30 a.m. Yes or no? You guys are very welcome. I will be sharing the link of the class for tomorrow in your email, on our page, on our Facebook discussion group, everywhere, so that you guys can see the link and join the class accordingly. If you have to share the link with your friends, please do so. And I'll see you guys tomorrow at 8:30 a.m. Before I leave, one more thing. If you guys are solving first aid with us in the class, what do you have to do in your own time? Solve UWorld. Very good. Okay, very good. Okay, solve UWorld in your own time. If you guys have problem solving UWorld, please let us know what questions you are facing difficulty in, and we will break it down in the class. Hope you guys have a great day. Thank you so much for joining the class, and thank you so much for supporting us. I'll see you guys tomorrow at 8 a.m. So with that being said, I'm going to conclude the lecture over here for now. And I'll see you guys tomorrow. Okay, bye-bye.